Society of India, I extend a very warm welcome to all our distinguished faculty members, delegates, and guests. May I request everyone to kindly adhere to the allotted time. As a gentle reminder, a buzzer will sound 3 minutes before the scheduled end of your session, indicating it's time to conclude. If you haven't submitted your presentation slides, I request you to please submit it in the backstage. Also, as a gentle reminder, please keep your phones on silent mode. We appreciate your cooperation in helping us to keep up the program schedule. Now, to deliver the welcome and introductory remarks, may I invite our program director, Dr. Jyoti Bajpai, IOSI founder and president-elect, clinical director, medical oncology, and clinical director, precision oncology, immuno-oncology, and research, Apollo Hospitals. Please give a big round of applause for Dr. Jyoti Bajpai.
So good afternoon, everyone. It's my extreme pleasure and privilege to address this audience, and a very warm welcome to our overseas guest, none other than Dr. Ahmed Tarini, who is a long-term collaborator, and at present he is a professor, very senior consultant at Moffitt Cancer Center, and he's also current chair for Global Access and Impact Committee of Society of Immunotherapy of Cancer, doing phenomenally good work in immuno-oncology space. I also would like to extend my warm welcome to none other than Dr. S.H. Advani, who doesn't really need any introduction to any oncology crowd in country and abroad. So Dr. Advani is actually the true pioneer of medical oncology in this country, and we are actually making a progress in leaps and bounds under his leadership since many, many years. He's also Padma Bhushan, Padma Shri, and so many accolades on to his credit. And with that, there are so many other faculty members, there are administrators, and there are students, fellows, everybody. You all have taken out time in your busiest schedules and here. So without taking much of the time, from Apollo Hospitals and Immuno-Oncology Society of India, I would like to extend a warm welcome to all of you and start the ceremony. So I will hand over the mic to, again, Ankita, the master of ceremony for today. Thank you very much.
Thank you, ma'am. We now move on to the ceremonial lamp lighting. May I request our dignitaries to kindly join us for the inaugural lamp lighting ceremony. I would like to invite Padma Bhushan, Padma Shri, Dr. S.H. Advani, Senior Medical Oncologist, Sushruth Hospital, Mumbai, Dr. Jyoti Bajpai, Dr. Amita Maheshwari, Director, Gynaecologic Oncology, Tata Memorial Hospital, Mumbai, Dr. Vandana Gaudi, Senior Consultant, Obstetrics, Gynecology and Robotic Surgery, Apollo Hospitals, Navi, Mumbai, Dr. Gautam Dithe, Consultant Dermatologist, Apollo Hospitals, Navi, Mumbai, Dr. Bindu K.S., Senior Consultant, Obstetrics, Gynecology and Robotic Surgery, Apollo Hospitals, Navi, Mumbai, Dr. Gauravi Mishra, Professor and Physician, Tata Memorial Hospital, Dr. Ranjit Bajpai, Senior Consultant, Radiation Oncology, Apollo Hospitals, Navi, Mumbai, Dr. Jaya Ghosh, Professor Medical Oncology, Tata Memorial Hospital, Dr. Swagata Tambe, Senior Consultant, HOD Dermatology, Municipal General Hospital, Rajawadi, Mumbai, Mr. Arunesh Puneta, Regional CEO, Western Region, Apollo Hospitals, Dr. Kiran Chingote, COO and Unit Head, Apollo Hospitals, Navi, Mumbai, Dr. Ravi Shankar, Director, Medical Services, Apollo Hospitals, Navi, Mumbai. May I request everyone to kindly assemble near the lamp. Thank you. May I request everyone to kindly take their seats. To chair the scientific session, it's my privilege to invite our program chairs, Dr. S.H. Advani and Dr. Anil De Cruz. Dr. Anil De Cruz could not join us this afternoon due to unforeseen circumstances. With your permission, sir, we shall now begin the program. The mic.
Good afternoon, colleagues. We are really very happy to participate in this seminar, and fortunately, we have an international guest on the faculty who is going to give us an insight into the immunotherapy and its application in the cutaneous malignancies. So I think that's an area which is really developing. Whenever we talk about in this type of the meetings, the questions always comes up, particularly with immunotherapy. Now, all of us know that we had for a long time, for half a century, our treatment was only the surgery, then came the radiotherapy, and lastly came the medical oncology in the form of the cytotoxic chemotherapy. Those were the three pillars of our treatment. But today I must admit that we have gone far ahead of this. The way we were treating before, to me it appears, was very infantile. But today what are we doing? We are targeting the tumor tissue without affecting the normal cells. And that's where we have now got what we call it targeted therapies. We target the mutation in the gene, because mutated gene produces an abnormal surface antigen. We target that, manipulate that, and get the best of the response. One of the example is lung cancer, where the targeted therapy has really made a huge impact. Similarly, the next thing which came up was the immunotherapy. Everybody thought that immunotherapy is simple. The way we were practicing immunotherapy 20 years ago or 30 years ago, what was it? And I must tell you that in malignant melanoma, what we were doing immunotherapy, intralesional BCG we used to inject. And we used to feel happy if one small tumor disappears, but other tumors will go on growing. That was the situation. And that was the immunotherapy, which is totally non-specific. But things have changed now. And why it has changed? Because the immunotherapy world has undergone the change. Although I'm sure many of you who are not in oncology, you must think that immunotherapy means stimulate the immunotherapy. That's not the immunotherapy at all. Today we don't stimulate the immunotherapy. What we do is, all the immune mechanism, if you look at the immune mechanism, which is all based on the T cells. So the antigen on the tumor cells stimulates the T cells, and activated T cells go and kill the tumor. That is the way it happens. But in nature, remember, nature cannot accept one-way traffic. If it is one-way traffic that you stimulate and tumor get killed, nature has no acceptance. For everything, there's a regulation, auto-regulation. It's regulated. How it is regulated? That activated T cells produces some substance, chemical, or chain of amino acid, which then inactivate the activated T cells. Look at it, how the nature has done. Why it is done? Because if you go on activating the T cells, ultimately it becomes harmful. It can produce autoimmune disease. That is what happens. So in malignancy, we are other way around. I want T cells to be activated forever, because then they can kill the tumor cells. So what I do, very simple. You stop the inhibitory pathway, which is inhibited. That is what today's immunotherapy we will learn. These are all we are inhibiting. The wording you see initially when people used to come and present to us that it is breaking the inhibitory pathway. It gives a break to the inhibitory pathway. Very few people used to understand that. But now we understand very much in depth because we have understood the pathway. So the pathway which inhibits the activated T cells is there. And what we do is, we cannot stimulate the T cells more. But what we can do is, we can remove the brake. If you remove the brake in the car, what happens? Car will go on and on and on. That is what is done in the immunotherapy. You remove the brake or block the brake. So I think today all of us are lucky that we will have a tremendous insight in the area of the immunotherapy, which has become the treatment, not only in many other cancers, but also main focus nowadays is on the gynecological malignancies. You must have read nowadays how the endometrial cancer in gynecology practice is increasing rapidly, basically because all of us are eating high-fat diet. Obesity is a major problem, and that's why the endometrial cancer is on rise. Of course, we have also the problem with the carcinoma of cervix. So today, all these conditions are being treated with the immunotherapy. Another few examples where the disease was fatal, I should say, I have seen the disease condition like malignant melanoma, stage 3 and 4, always fatal. They never used to survive. But today, majority of them will have a good response, and many of them also can be cured. So that is where we are at present. So I think this transformation of an incurable disease to become a curable disease is one of the factors why we are gathered here, to learn more about it. So I think with these few words, now I would request the doctor to carry on with the next session. Thank you very much.
Thank you so much, sir, for your insights. For our first scientific lecture, may I invite the chairpersons, our leading dermatologist, Dr. Gautam Didhe, Dr. Shweta Agarwal, Dr. Meghna Fiske. I request you to kindly take the stage. Now I invite our speaker, Dr. Swagata Tambe, to deliver her talk. Ladies and gentlemen, please give a huge round of applause for everyone.
Good afternoon, faculty and delegates, and a very warm welcome to Professor Ahmed Tarhini to Apollo Hospital, Navi, Mumbai. We'll be starting the first session, which is an overview on cutaneous malignancies which are seen in the Indian scenario. Over to Dr. Meghna Fiske.
So good afternoon all. On behalf of my co-chairpersons, I welcome you all again for this wonderful CME. And the first talk is on cutaneous malignancies, a dermatologist's perspective. This is going to be delivered by Dr. Swagata Tambe. She is HOD Department of Dermatology, Rajawadi Hospital, and she happens to be a very brilliant student of mine. So, and she has many publications and awards to her credit, and she has given many lectures also. So over to you, Dr. Swagata.
Thank you, respected chairperson, for the kind introduction. Good afternoon, everyone. At the outset, I would like to thank organizers for this opportunity. Special thanks to Dr. Gautam Dethe sir. So today we will be discussing the different aspects of the cutaneous malignancies because we have a mixed population. Let me just add a little introduction. Like we as a dermatologist see a lot of cases, spectrum of diseases starting from infectious, inflammatory, then autoimmune conditions, benign, malignant, pre-malignant conditions affecting the skin and soft tissues, nail, hair. These are our prime specialities, but we also end up seeing a lot of cases or a lot of our diseases presenting on the oral cavity, genital area, especially sexually transmitted diseases, external ear, and the breast. So what is the role of dermatologist if we start about, then it is often we are the first one to see the lesions which are present on the exposed part of the body. And we stratify the risk based on the history and cutaneous examination. Then we confirm the diagnosis by doing dermoscopy and biopsy. And then we guide the next step in the care. So we try to start with the prevention, early diagnosis, treatment planning, and then we are also there for the monitoring. So this is a cell origin classification of cutaneous malignancies. So we have keratinocytic malignancies, which include benign tumors like seborrheic keratosis, basal cell and squamous cell carcinoma. Melanocytic lesions, which are pigmented lesions. So they have benign nevi and malignant melanoma, which we'll be discussing in subsequent sessions. And adnexal tumors containing mostly the hair and appendigeal structures like eccrine, apocrine, and sebaceous glands. Soft tissue tumors like dermatofibrosarcoma protuberans. And then we have hemolymphatic malignancies like lymphoma. And we also end up seeing a lot of cutaneous metastasis where we diagnose it as a cutaneous metastasis, and then with the help of oncosurgeons and pathologists, we try to look for the underlying primary. So if we look at the load of keratinocytic tumors, we can see they rank among the 5th most common cancer, especially the basal and squamous cell carcinoma. And while cutaneous melanoma is little rare, so it stands on the 17th. The higher incidence of both the malignancy is in the Western countries like Australia, North America, Europe, while India tend to have lesser incidence of it. But the important point is if we look at the mortality, if you can see being less common, melanoma has a more mortality. Now coming to the Indian studies, there are less Indian studies about the overall cutaneous malignancies, and they are relatively rare. That is what it comes from the literature, and say 1 to 2% of all diagnosed cancer. But there is a lot of underreporting because these malignancies are seen by different physicians. Many of them are treated at OPD level, so not documented. And there is a lack of registry where all physicians enter or document all the cancers they are seeing. BCC is the most common malignancy in India, but in contrary to the Western population, where it is seen on the sun-exposed area, we have more SSCs coming on the sun-protected areas than on the scars, non-healing ulcers, burns, and inflammatory dermatosis like lichen planus, lichen sclerosis. Cutaneous melanoma is rare in India, and in contrary to Western population, where it is more on the exposed part, we have it on the acral areas, subungual areas, and mucosal sites. And in India, if we talk about malignant melanoma, it usually comes from the northern and eastern part of the country. So there are various risk factors which include cumulative UV exposure for all 3 keratinocytic carcinomas, skin type and genetics, again goes for all 3 carcinomas, and xeroderma pigmentosum is a genodermatosis where patients are prone to develop malignancy very early during childhood only, especially the basal cell and squamous cell carcinoma. Immunosuppression, because a lot of patients nowadays are suffering from autoimmune conditions, HIV, they are on chronic immunosuppressive therapy, so any suspicious lesion should not be neglected in this patient. As I told you, non-healing ulcers, burns, and lichen sclerosis, these are the certain conditions where we have to be proactive and diagnose or monitor this patient for development of malignancy. And obviously with HPV, human papilloma virus infection becoming the most common sexually transmitted infection, and we in India also see a lot of patients presenting with the vulvar carcinomas and anogenital SCCs. So these are some of the lesions. They look like malignant melanoma, but these are benign lesions. We can see some lesions which are smaller in size on the face, and some of the lesions are looking more pigmented and darker. But here we can do a biopsy and differentiate between them. Now coming to the Bowen's disease, this is carcinoma in situ. So it can be seen on the exposed part of the ear, then as a verrucous lesion on the chest, then eczematous lesion on the leg, and it can also come on the genital area. So here we can see in histopathology, the full thickness dysplasia of the epidermis. Coming to the basal cell carcinoma, so there are low risk morphological types. So we can stratify the risk based even on the morphology of the lesion. So low risk one are the superficial BCC. We as a dermatologist manage this ourselves also with sometimes topical medications. Then we have nodular BCC and rodent ulcer, which are locally destructive lesions, but less chances of metastasis. Then morphological differentiation, it's not working. So then pigmented BCC sometimes resemble a melanoma. So here we can confirm the diagnosis on histopathology. Now coming to the locally aggressive and also the high risk morphology of basal cell carcinoma, that is a morphia form BCC. If we can see here, it looks very flat lesion, sclerosed lesion, and there is a small ulcerative lesion at the edge. And here you can see the same, another patient who has been having this disease. The contrary is it is very aggressive, locally destructive. Here we can see the destruction of the inner ear, middle ear, and the external ear. But this patient has underwent almost 8 to 10 biopsies over a period of 3 to 4 years, but none of the biopsy could detect. So here you can see it is very superficial. Then most of the areas is fibrous. Then it can come as a part of certain syndrome like Golin-Gorge syndrome. Here you can see basal cell carcinoma appearing very early in the age, and then there are lesions are very small, looking like just moles. Multiple lesions present on the exposed areas as well as the hidden parts of the body, and they have associated features like palmar pits, malocclusion of teeth, and we can see the odontogenic cyst also. Then non-syndromic also, in the same patient we can see multiple morphological aspects of the basal cell carcinoma. Then there are certain glandular differentiation of basal cell carcinoma like adenoid BCC and those presenting with the sebaceous differentiation. I'm sorry, I cannot show you the pictures here. So then squamous cell carcinoma, here we, as I told you, we see more squamous cell carcinoma coming on the hidden parts of the body. So here we can see the elderly people, and they are usually diagnosed very late in the course. We can see the vegetative lesions, the bigger size of the lesions, foul smelling, infected. And the patient on the left side is the one who had pemphigus, so she used to have chronic ulceration on the lips, and later she developed squamous cell carcinoma at that site. Then it can come on other inflammatory condition, like in first we have seen squamous cell carcinoma coming on a porokeratosis. Then in the second picture, we can see it is coming on a chronic itchy condition called as lichen amyloidosis. And again, ear. There are certain areas where there's a fusion of embryonic plates and they're more prone to develop squamous cell or basal cell carcinomas. Now coming to the malignant melanoma, I will not go into the details of this because we have further sessions on it. I'll just show you a few cases, what we have seen. So this usually present as a hyperpigmented plaque, sometimes ulcerations can be seen, and here commonly the general practitioner diagnoses it as eczemas, and it is treated just like that without any biopsy till he reaches the dermatologist, and we can see the classical histopathological changes of malignant melanoma. Then similar patient, elderly with a nodular hyperpigmented lesion, less ulceration, and here we can see the spindle shape and pagetoid cells on the histopathology. Another patient with a subungual melanoma, where we can see the hyperpigmented jet black plaque over the periungual and subungual areas. None of the patient had metastasis at the time of presentation, but later they developed metastasis. So dermoscopy is a very important tool for us, not only to differentiate between the benign malignant conditions, nevi and melanoma, but it also helps to rule out certain common conditions, for which we unnecessarily need a biopsy. So another mimickers of nail melanoma, this is a fibrous tumor, fibroepithelial tumor, onychomatricoma, almost looking like a melanoma. Then longitudinal melanonychia is also very common. Here we can see an elderly patient who has subungual lentigo with epidermal proliferation, and there we can see a younger patient with a junctional nevus. Then another 8-year-old patient presenting with a diagnosis of clinical diagnosis of melanoma, and when we do a dermoscopy, we can find out the less involvement of the matrix proximal nail fold area, and here we can see the increased melanin in the epidermal keratinocytes, but there are no melanocytes in the dermis. So it is a nail matrix nevus. Then nail squamous cell carcinoma is very common, so any non-healing ulcers on the digital area, nail area, we have to rule out this. One variant of malignant melanoma called as the amelanotic melanoma, so it will not come with the color. So it will come as an ulcerative lesion or keratotic lesion on the acral areas. Then we also have appendigeal tumors like spiridinocarcinoma, very aggressive tumors with lifespan of just 12 to 20 months. We can see more commonly in the elderly patients. Then sebaceous carcinoma. This is also seen in elderly patient, and here we can see a asymptomatic hyperpigmented nodule on the scalp, but if we see closely, there is a nevus here in the in the background of the lesion. So in younger patient, you can develop it more early also. Then again, a mucinous eccrine carcinoma. This is a very relapsing tumor. In this patient also, it has recurred 3 to 4 times after excision. So we have to be very vigilant in monitoring this patient because they are prone to develop more recurrences. Then another tumors which look very destructive and very horrendous, but sometimes they are benign. It is just the duration of the lesion which makes them grow, but they can affect the breathing and eating. So this can be excised to improve the quality of life, but this is a benign tumor. Then coming to the soft tissue tumors, we have this dermatofibrosarcoma protuberans, which commonly misdiagnosed as keloid and scars for a very long time till the patient reaches us. But if you just do a biopsy, you can see a spindle-shaped cells arranged in a storiform pattern, very classical of dermatofibrosarcoma. Now coming to the cutaneous metastasis. So this case is a 45-year-old male who presented with this flesh-colored nodule involving the lateral aspect of the face and face, neck, ear, and here we can see the torticollis and the erythematous infiltration of the back. So we just did a biopsy from the nodule which was suggestive of tumorous cells in the dermis, and which on further pathological evaluation and immunohistochemistry was diagnosed as adenocarcinoma, but we could not find the primary for this lesion. But sometimes it is easier to find primary, like we can see the signet cell. This elderly male presented with multiple nodules all over the body. We did a biopsy and there was signet cell. We worked him up for carcinoma stomach and it came positive. Another patient who had a cutaneous metastasis over the pubic area, and if we can see the epidermis looks normal, everything is in the dermis. So all classical changes of squamous cell carcinoma were in the dermis. So we can see the horn pearls in the dermis while the epidermis is absolutely unaffected. Then cutaneous lymphomas, cutaneous T-cell lymphoma is also very commonly present to dermatologists at patch lesion, plaque lesion, and nodular lesion. So histopathology is very diagnostic. Then we have this patient of breast lymphoma who presented with the neutrophilic eccrine hidradenitis as a papillopustular, extremely itchy lesion on the palms, and on examination we could find the tumor in the nodular lesion on his breast and the right arm. And here we can see the lymphoid aggregates in the dermis, which consisting of atypical T cells. Then we have angiosarcomas also, which are commonly seen. Just last 2 minutes. Angiosarcomas are commonly seen on patients who have filarial lymphedema, very aggressive tumor, and it recurs on even on the amputation stump. Then this is again very common. These patients are commonly misdiagnosed Paget's disease of breast as nipple eczemas, psoriasis. So this patient we have biopsied, it came out to be Paget's disease, and then we investigated, she had ductal carcinoma. While the second patient, she was already a case of CA breast, and she was diagnosed with lumpectomy, and she received chemotherapy and radiotherapy 6 years back. And she had this lesion for 2 to 3 years where she was having an ulcerative lesion on the nipple. And she was already following. Her last PET scan was done just 5 days ago. That was absolutely normal. And then we did a biopsy. It came out to be a Paget's disease of breast. So it can come even after the treatment of breast carcinoma. Then there are certain pre-malignant lesions, which are Bowen disease and erythroplasia of Queret. If we do a biopsy and if we excise them or treat them before, then there are less chances of developing squamous cell carcinoma. Otherwise, you see squamous cell carcinomas coming on lichen sclerosis. So any depigmented area you see on the genital area, it is not vitiligo. It can be lichen sclerosis. Ask about the history of itching and symptoms related to this. And if you can diagnose it early and treat it, then squamous cell carcinoma can be prevented. Another patient where penile eczema was treated as for like 4 to 5 years, and if we do a biopsy, we can see a squamous cell carcinoma. Then we also have some paraneoplastic syndromes like dermatomyositis. This patient presented with classical dermatomyositis, and then on screening, we found a gastric carcinoma. Then another patient with pemphigus was diagnosed to have a carcinoid tumor. And sometimes after radiotherapy also, we can get a dermatological diseases. So this was a radiotherapy-induced pemphigus. So just to summarize, the prevalence of cutaneous malignancy is increasing, and we have to be very sure about what kind of patients we are looking at. Clinical presentation can be classical, sometimes it can be atypical. When to suspect is long-standing lesion, atypical presentation, atypical site, and no response to treatment. Early diagnosis improves the prognosis. Dermoscopy and skin biopsies are very important for the dermatologist to at least suspect and confirm the diagnosis. But once we confirm the diagnosis, the treatment is multidisciplinary. We have to take help from the pathologist, surgery, oncology, oncosurgery, and together we can help the patient. And again, we play also important role in the prevention and monitoring. Thank you so much.
Thank you, Dr. Swagata, for such a wonderful talk covering the cutaneous malignancy in details with such a beautiful skin lesions pictures and histopath pictures. I think, ma'am, we move to the second session, or any questions we can take?
I think one very quick question, if it is there, otherwise in the interest of time, we'll move and we will handle the questions in the detail.
Yeah, fine. So before concluding these sessions, I would like to thank specifically Dr. Swagata for accepting our invitation as a speaker to talk on cutaneous malignancies, and also the organizers, specifically Bajpayee Madam, for inviting as chairperson for these sessions on the behalf of my co-chairs. Thank you, Swagata. Thank you, Madam.
Thank you, everyone. For the next session, may I invite Dr. S.H. Advani and Dr. Ranjit Bajpayee to kindly take the dais. I now invite Professor Ahmed Tarhini, Professor of Oncologic Sciences at Moffitt Cancer Center, Florida, USA, to deliver his lecture. Ladies and gentlemen, please give a huge round of applause.
Thank you, everybody. It's a true honor to be present with you today in this exciting meeting. It's been great to meet most of you, honored to meet Dr. Advani in person, and grateful to my friend, Dr. Bajpayee, for giving me the opportunity to be part of your meeting and talking today about immune therapy. And here again, I'd like to say thank you to Dr. Advani for giving an excellent introduction, setting the stage for my talk about immunotherapy of melanoma. And my talk will be focused, in the interest of time, primarily on LAG-3 inhibition and the updates in the LAG-3 inhibition space. And I wish we had more time to talk more, but I think Dr. Advani gave a great introduction in that regard. All right, so starting, with
See, many times, this is the thing which we are hearing, and let me also tell you that in China also this was the kind of situation where also it was considered very rare, and when one of the one of the oncologists started collecting the data very meticulously, and they made the formal registry, now he's one of the top seeing melanoma person in the world. So I think we need to really work on our epidemiology and our registry patterns. That is the most important thing. Also, let me give you this example, that when I was in Tata Memorial, I kind of established the Melanoma Center for Excellence within Tata Memorial, and when this became quite prevalent, and even the GI surgeons, the all dermatologists, etc., they were sending cases to us. So we were seeing a good number of cases, and we publish the highest number of data from this part of the world. So I think we need to more work on that cohesively. So Advani sir, what is your comment on this part? You know, melanoma, everybody say that it is rare. What is your experience?
I think I must say that we used to see very few cases, but now people are aware about it.
Correct.
And that's where nowadays we see many more, particularly uveal malignant melanoma. Nowadays is clinically diagnosed. So many ophthalmologists refer the patients without biopsy proof, but they are very important. Of course, we see many uveal melanoma with a liver metastasis. So that's very common presentation, and you can find it out. Second one where we see is, of course, a cutaneous melanoma going to the inguinal region and then becoming metastatic. The third, which is common, is the visceral malignant melanoma. Rectum. Last week I have seen 2 new patients of the visceral metastasis. And so I think the people are becoming aware about it, and diagnosis is being made more correctly. And I think we have the new treatment as well. So I think
Absolutely. So maybe I'll quickly touch base. Darshit, your take, and Siddharth, and then we'll ask Dr. Tarini the same.
So rightly mentioned by Advani sir, ma'am. Now the cases are increasing, and we are seeing more. I mean, as mucosal medical oncologists, we'll not see much of cutaneous, but we'll be seeing more of mucosal melanomas. But I would say around 1 or 2 cases a month we are seeing.
And you were part of our melanoma clinic also in TMH couple of
Yes,
times.
under your, you were my professor, ma'am. Yeah.
So I just agree with that. Previously it was quite less, but still it is less only. But things are improving. We are getting the diagnosis at relatively earlier stage. Previously, many patients used to come after everything has gone. It is very hard to treat. Now we are seeing a little bit of early stage.
So with the better diagnostic, with better awareness, we are seeing more cases, and also dermatologists are more aware. Some other, people, surgeons, they are more aware, and they are sending also in time. Dr. Tarini, your take. How many cases and how is the practice pattern there?
Well, in the United States, we see about 100,000 cases of invasive melanoma diagnosed yearly, and about 100,000 melanoma in situ. But clearly there is, the incidence is primarily a cutaneous melanoma that's related to sun damage and, UV exposure and so on. As compared to India, the numbers are, for example, if you say it is, about 55% mucosal melanoma in India, it's about 5% in the States or in the West in general. Acral melanoma is about 17% based on your data in India. It's 2 to 3% in the US for acral. So it's primarily cutaneous, melanoma overall. And I think one would be concerned about the lack of awareness by the practicing, primary care providers, and referring those patients to medical oncology, or so getting referred so these are recognized and treated the right way. So it could be under awareness, and obviously you and your colleagues' efforts increasing awareness probably will have this better defined.
Sure. So, just for everybody's interest, I believe that a lot of people here in audience would be watching movies, especially the couple of students here. So this movie, The Elephant Man, was a critical and commercial success with 8 Academy Awards nominations. And in this particular movie, the main character, who was actually having a rare disease, forever imprisoned inside his hideous, deformed body, the unfortunate Victorian fairground attraction exhibit John Merrick, who was milked for every penny by the sadistic showman Mr. Bites. And what happened in this particular movie, and what happens in the end, I will disclose towards the end. But it is very, a very intense movie which make us really, really sad. And I give this analogy in my, rare cancer presentations, because still, as my colleagues rightly said, that we are finding little incidences increasing because of better diagnostic, other things, but still it's considered rare in this part, and because of being rare, less awareness, less, streamlined care. Many times these people are not having, a course which we should expect. So that is the biggest challenge, and this movie gives me that analogy. And then I would also like to tell you that, what has been a nihilism completely, especially in my limited lifespan when I was a resident in All India Institute of Medical Sciences in Delhi. Couple of years ago, that time malignant melanoma with metastasis especially used to be a death sentence, and people used to write their wills. 6 months survival. But in my very limited lifespan, now I'm seeing the epidemiology is completely changed. And this change has been done because of these many drugs, these novel molecules which are come into picture. And now, it's comparable to locally advanced breast cancer. So we are talking to our patients with metastatic melanoma, and who forgets Jimmy Carter? In spite of having a brain metastasis, he was having 5+ year, good survival, good quality of life. So this is the beauty of these novel agents, and this is very real. This is nothing fancy. So the 1 year survival with a couple of months to 1 year survival of many years, I would say at times we are talking about indefinite survival, and 1 year also 70%. Dr. Tarini, how you see this data, and what is your comments?
Exactly as you've presented, that it has been, exciting 15 years or so, starting with anti-CTLA-4 ipilimumab itself, pushing the survival curve up, about 20% or so, and now going up to 50% at 5 years with combination immunotherapy. But now we have also other exciting things in development, right? We have development in cellular therapy, for example. We have lifileucel approved in the second line. It is still treatment harvested from the tumor itself. It is cumbersome, but we see now more development in the cellular therapy space with
Ladies and gentlemen, welcome back. We now begin with the second scientific session dedicated to advances in gynecology oncology. For the first lecture, our chairpersons would be Dr. Vandana Gaudi and Dr. Meena Shrikant. Please give a big round of applause. I now invite Dr. Gauravi Mishra to deliver her lecture on evolving trends in women's cancer.
At the outset, let me thank Dr. Jyoti Bajpai and all the organizing team members for having me here. So my topic for today is what are the trends in women's cancer and how is it changing over time? To begin with, what do we mean by women's cancer? So it mainly refers to the gynecological cancer or some cancers that are disproportionately that affect women. So mainly my talk would be concerned with what are the trends with respect to breast cancer, uterine cervix cancer, ovarian and endometrial cancer. Now this is a very important, it's very important to understand the trends. The reason being that globally if we see, then cancers are the second leading cause of death among women. And around 14% of the cancers, deaths among women globally are due to cancers. So it's the cancers among women play an important role, and a large share of these cancers are actually preventable or curable when they are detected early. So there is a dual reality of high burden and high preventability that defines the public health importance of women's cancer. Let us see as to what's going to happen in future. So this 2024 data is the latest data that has been released by the IARC just this month. And we see here that currently there are 10 million cases of cancers among women, and that's going to rise by nearly 60% by 2050. So it will be around 16 million by 2050. This is the global figure. And again, when it comes to deaths because of among women, currently there are 4.28 million cancer deaths globally among women, and that's going to rise to nearly double, that is 7.44 million by 2050. So it's a huge both incidence as well as mortality that we are going to face by 2050. And then if we look at the blue bar over here is what are the rates in 2024, and the red bar is about 2050. And we can see here that the major burden, both in terms of in the incidence as well as deaths, it's going to be in the Asian countries. And this major rise is going to be determined by the rise that happens in the Asian countries. Now this is the global scenario, and we can see here that breast cancers occupy nearly 1/4 of the cancers among women. And then of course, if you look at uterine, cervix and the endometrial cancer, they are 6% and 4%, whereas that trend also follows similarly. Now, if we look at what are the trends, what were the trends over the last 3 decades from 1990 till 2021, we'll see here, this is again in terms of just the numbers. And hence you see that the numbers are rising everywhere. It is but natural because of increase in the population size that you see larger numbers with respect to breast, cervix, uterine and ovarian cancers. Again, the entire rise is only because it is the numbers that I'm putting here. However, if we look at the age standardized incidence rate, which is per 100,000 population or per 100,000 women, then we'll clearly see here that there is an increasing trend in breast cancer. Again, this is a annual percentage change, estimated EAPC's estimated annual percentage change, and that is 0.4% per year in age standardized incidence. Again, these are not numbers, these are the rates. You'll see a 0.4% increase in the breast cancer, again 0.54% annual increase in terms of uterine cervix cancer, uterine cancers, whereas for cervix cancer and ovarian cancer, there is a decrease in the trend in terms of the age standardized rate by 0.54% for cervical cancer and ovarian cancer by 0.38%. These are again the incidence figures. However, when you look at the deaths, again, we have to see that the upper bar diagram is in terms of numbers. It is not the rate, it is numbers. And numbers, you are expected to have higher numbers after 30 years, right? But even after 30 years, you will see that the cervical cancer number of deaths have reduced despite the increase in the population. And when you look at the down here over the, if you look at the rates over there, then you will see that there is an annual decline in the annual percentage in terms of age standardized mortality rates for breast, for cervix, for uterus, as well as for ovary. This just represents that there is a good treatment that is available there. That's why the age standardized rates have gone down everywhere. Mortality has gone down everywhere, despite there being an increase in the age standardized rates for uterine cancers and for breast cancers. But the mortality rates in terms of ASR have gone down for all 4 cancers. Now, what about India? In India, currently we have nearly 7.8 lakh cases among women, all cancers together, and that is going to increase to nearly double, nearly 1.4 million cases by 2050. Similarly, the number of deaths are expected to double from 4.5 lakh to 7.6 lakhs by 2050. Now, in terms of the distribution of cancers among women, in India, nearly 1/3, this is again the latest data, that shows that 1/3 of all the cancers diagnosed among women are breast cancers. That means amongst every 3 women that you see with cancer, 1 is going to be a breast cancer case. And again, though globally cervical cancer was at number 4, we see that in India it's on number 2. And look at the difference in the age standardized rate. For breast cancer, it is 31.2, whereas for cervix, it is 10.5. So there's a huge difference. There's a lifetime risk of 1 in 29 for an Indian woman developing breast cancer. For cervix cancer, is 1 in 83. And for ovarian, it is just 1 in 149. That is the current trend. And similarly, it follows for death rate. So if you look at the age standard, this is crude incidence rate, and you can see that it has been rising for India all through. Now, the real picture, of course, IR gives a good estimate, there's no doubt about it, and the data comes from the population-based registries. But if you look at the real picture, it comes from the registries, the population-based registries, and then also from the hospital-based registry. If you look very closely, then you will see that these are the different registries that are there in India, and this is from the real registries that the data has been taken. You will see that if you look at the breast cancers, mainly it's the urban places where you see there is a high incidence of breast cancer. Whereas for cervical cancer, you will notice that the incidence is mainly in the northeast and then in rural areas. Again, northeast is mainly rural areas, and in rural areas like Barshi near Solapur, where the incidence is high. For ovarian cancer, there is no such trend. Whereas for endometrial cancer, again, the trend is towards urban areas. So you see a high incidence of endometrial cancer and breast cancer in Hyderabad, Chennai, Bangalore, Delhi, etc. And then what is the lifetime risk of a woman to developing a cancer? It varies throughout the country. You will see that in Hyderabad and Bangalore, the risk is as high as 1 in 11, whereas if you look at Meghalaya, the risk is just 1 in 48. So our country is very diverse, and the risk of getting cancer also varies very widely. These are again the real data from population-based registry, and you will see here that breast cancer, the trend is increasing in all registries. Upper to in Mumbai and Chennai are the urban registries, and Barshi is near Solapur. It's again a rural population-based registry. Similarly, Dindigul is a rural registry. So we can see that the trend of breast cancer in terms of age standardized rate, it is rising in all the registries, be it urban or rural. But you will see that the largest rise is in rural registries, where initially the rates were very low. They are rapidly rising in Barshi as well as in Dindigul. Again, the rates here mentioned percentage is the annual percentage change in terms of age standardized incidence rate. For cervical cancer, again, you see that the rates are decreasing in urban registries like Mumbai and Chennai also, and also in the rural registries like Barshi and Dindigul. However, the largest decline has been in Chennai and Dindigul. And then ovarian cancer. Ovarian cancer, Mumbai, Chennai, Barshi, Dindigul, everywhere actually the rates are rising. In Mumbai, you see a slight decrease of 0.4%, which is very insignificant. But overall, if you see all over India, the rates of ovarian cancer are increasing. Corpus uteri cancer, again, the rates are increasing in all registries. Again, Mumbai, Chennai, the urban registries, and Dindigul, the rural registry, everywhere you see that there is an increase in the rate, but the largest increase has been in Chennai. So overall, if you club the data from all the registries, you will see that there is a clearly increased age standardizing rates increasing over a period of time. The trend is increasing for breast cancer, the trend is increasing for endometrial cancer and ovarian cancer, and there's a sharp decrease for uterine cervix cancer in all the registries. At what stage the cancers are diagnosed in different registries? If you look at that, then in most of the registries, the breast cancer, ovary cancer, and uterine cervix cancer are diagnosed at loco-regional stage, whereas for corpus uteri cancers, they are mainly diagnosed at the localized stage. I mean, there are more number of cancers diagnosed in the localized only phase. So what are the reasons responsible for all these trends? Though we are quite aware of it, it's a change in the dietary pattern, lack of physical activity, obesity, high use of tobacco, alcohol, our occupational risk that has gone up over a period of time, the shift duties, the industrial exposures, the pollution, infections, and yes, the reproductive risk factors that are changing, the age at menarche going down, the age at menopause going up, less number of kids, delayed childbirth, less breastfeeding, nulliparity, all that has contributed to increase in the risk of breast, ovarian, uterine cancers. And then there are gallbladder and thyroid cancers, which are not actually included in the malignancies, but we can see here that there is a clear increase in the trend of gallbladder as well as thyroid cancer. So this is for the gallbladder cancer, and we can see that Mumbai is showing a trend of 5% annual percentile change every year, and so is Chennai. There has been also increase in rural registries like Barshi and Dindigul. So there is an increase in all the registries. Now, whatever trend we have discussed till now, whether increasing, decreasing, that are a number of cases, the urbanization that has been now started in the rural areas also, leading to increasing breast cancer even there. The decline in the fertility, the earlier menarche, late menopause, our lifestyle factors, obesity, less of physical activity, use of alcohol, tobacco, diet and nutritional transition. And then of course factors related to parity, nulliparity, less children, less breastfeeding, the endogenous hormones and the exogenous hormones that are playing a role. Of course, with the decreasing trend in the future especially, we will have to give a lot of credit to the HPV vaccines. And then environmental and occupational risk factors also play a huge role. We need to know the reasons, as the prevention is very important, with the now WHO supporting a single dose of HPV vaccine and India producing its own vaccine. I think at least the cervical cancer rate, though they are going down even without a well-established vaccination program, it is soon a disease which can be near eliminated. And we need to focus on lifestyle and metabolic risk factors, weight management, physical activity, diet, risk stratification, encouraging breast. She's an expert with talking, when exactly to do the risk-reducing surgeries and the other medications that could be given to reduce the risk. And of course, this has to be a shared decision-making process. So again, future directions, establish what we are going to do in future. And again, Dr. Jyoti is here. So precision prevention, multi kits, at least 3 kits which are in really advanced stages, and the reality still exists that we have not even reached 2% of the population with population-based screening till now. So the day is not far away when the detection kits will be as high as it is. And then AI-driven cancer screening and cancer detection kits are on the horizon, wherein even in the remote areas, you just go with the AI device and you need not really train your ASHA. Who really needs to be screened is something that's going to play a huge role in the future. So these are the references that I have used, and thank you. If there are any questions, I'll be happy to take up. Thank you.
Is there any questions? Are we taking the questions now? So I have a question, and thank you for the talk. It was very informative. I think I missed the first couple of slides. There was one thing that I would like to question you. Do you have any data to support the view that the amount of hormones which are being injected in the animal husbandry industry, is it contributing to the increased reproductive cancers that we are seeing? Is there any study we have, international, India?
There have been talks about this, but currently I
doing a great job in stopping trees, and I believe the next step should be some control in animal husbandry industry, where there is so much use of oxytocin and other steroids and other hormones, yes, to increase the production. There was one more thing I would like to ask you is you showed us that the trends in cities like Chennai, Mumbai. Now, the study was conducted, is it because the screening is stronger or the reporting is stronger and therefore you find in urban places the concentration more, or population to population is the active incidence percentage wise more? Little clarity on that, please.
Yeah, two things for this. One is that a hospital-based cancer registry, it can have a biased data because, for example, to oppose or some consultant is very famous for putting gallbladder in this particular hospital, so all people come there. But when it comes to population-based registry, the data is not biased. In fact, Bombay Cancer Registry is known to have 99% accuracy. Diagnosis, whereas in a rural area, the women may just die of abdominal pain without even a diagnosis. Having said that, a lot of efforts are being done in terms of verbal autopsy. That is, if you don't know a cause of death in a region where there is a population-based registry, you go and interrogate them to identify what were the symptoms, and from the symptoms you try to establish the cause of death. And there's a lot of work going on with respect to standard. Say that from population-based cancer registry, so you get quite an accurate data. And these are again the trends. We have in India 11% of our population that is covered by any kind of cancer registry. Even if you look at US and other countries, it's 11 to 20% that is covered, though the number of registries are more, but the population covered is kind of that much. So these are real trends that we are seeing. There are some cancers like thyroid that are getting more diagnosed, and so we are seeing a trend. But with regards to breast, cervix, I mean, till 2 years back, I mean, this data is just released last week, and 2022 data showed that we had cervical cancer 120,000 cases, and today we see that there are just 75 to 80,000 cases. So there has been a drop, and this has been despite vaccination or something, because even when the vaccination comes, it's going to take 2 to 3 decades to see at the population level for sure.
Thank you.
I had a question for you. What is your opinion about HRT in menopausal women? Because we have the Menopausal Society advising HRT for almost 10 years, 5 years at least. So how do you look at it?
So we normally describe it as a risk factor necessary. I mean, we put in the risk factor bracket.
What would be your advice looking at the increasing trend?
Yeah, so we actually don't advise for it. Yeah.
Okay, and then we've seen in the slides too, there's an increase in the uterine cancers and the breast cancer.
Yeah.
And it is more towards the younger population too. So any change in screening methods which you all advise?
Being a preventive person, we more about population-based screening, and there is enough data to say that screening with mammography is good. But below 50, we recommend clinical breast examination, because this is again from level 1 evidence that has come from randomized control trial. It's not about my opinion or someone else's opinion. Above 50 years, mammography shows the reduction as significant reduction in mortality. But when it comes to below years, we advise clinical breast examination, and again that has been established only with our randomized control trial.
But that comes with every health package, right? Whether below 50 or above 50, I think they all come with a mammogram or an X-ray mammogram.
We do a population-based screening, and that is from 30 years onwards.
Another thing which we as gynecologists, patients do come to us after cases of cancer, the treatment, who have been operated, treated,
Yeah, so for high-risk patients, again, the really high risk that we are expecting it would be annual mammography or mammography every 2 yearly. Above 40 years, we will go for mammography straight up.
The post-op patients, treated patients is what I mean, the follow-ups?
Yes,
I think it was a very thought-provoking session as usual for Dr. Gaurav Krishna. So let me tell all of you, she is leading the preventive oncology efforts for entire country, and we have a lot of collaboration internationally also. We were collaborating while I was with Dr. for many years. There is phenomenally good work which is being done. So I see ultimately we will follow some important professions, and we will be collaborating for your efforts. And we can handle other questions, later on, because it's quite interesting and thought-provoking. So I will now pass on. Am I audible, right? So I think I will call upon Dr. Bindu, please to come here and will hand over the moment to Dr. Ranjit and Dr. Jaya. To hand over the moment. To all of you. Dr. Banda, you also come, so all three.
We have Dr. Gauravi Mishra. Ladies and gentlemen, please give a huge round of applause. I request Dr. Ranjit Bajpai to felicitate Dr. Vandana. Dr. Meena Shrikant. Ladies and gentlemen, please give a huge round of applause. Now let's move on to next session, advances in gynecological malignancies. The chairpersons would be Dr. Vandana Gowdy and Dr. Rohini Kulkarni. The speaker would be Dr. Jaya Ghosh. I request everyone to take the stage.
Okay. I thank Dr. Jyoti for inviting me, and somebody can maybe just time. I don't, and you can stop me if I'm exceeding. So thank you all, and I have been asked to cover both advances in ovarian and cervical cancer, so I'll try to be as brief as possible. And we all know that ovarian cancer is not one cancer, and but today we will be mainly focusing on the high-grade serous, and it is well known that it is because of the impairment in DNA damage repair which causes the BRCA-ness, and that is what causes sensitivity to both platinum and PARP. So one point that I would want to probably specify here, especially if there are any students, is that what do we test when we get a patient of ovarian cancer? We know that we have the DNA damage repair pathway, so of which BRCA is the major player, okay? And there are other players in that pathway like the RAD51, CHEK2, other players. So there also can be a mutation in that, and that is the whole homologous repair pathway. So the one distinction that we need to understand is that, sorry. Okay. So the one distinction that we need to understand is that a defect in the homologous repair pathway is not synonymous that it cannot repair the DNA. So if there is a mutation in the BRCA, that definitely means, like, your captain of the team is out, so the cell can't repair the DNA. But if other members of the team are out, then it can still, you can replace your player, so it can still repair the DNA. So HRR is not equivalent to HRD, and this becomes important in what we order and how we treat and what drugs we give. So just a thought on that. And so therefore, what we need to check is for BRCA1 and 2, and that can be germline in the blood or in the tissue, somatic, and the HRD testing. And so as per the guidelines, currently all women with epithelial ovarian cancer should be tested, but we know that it is very rare in mucinous cancers and clear cell cancer, and so the recommendation is to test for MMR in these patients. And of course, if we don't test all patients, we'll miss out patients who are don't have a family history, about 20% of these patients. And the million-dollar question when a patient with high-grade ovarian cancer comes to us is whether to do the germline first or the somatic or the HRD. So because, germline is one of the most robust markers for benefit of PARP inhibitors, therefore I think it is important to do the germline first, and if you do the somatic, you might miss out on about 5% of these patients. So maybe a germline first, and if it is negative, you can go ahead with the HRD testing. And this is what I was wanting to highlight, that non-BRCA HRR, meaning something like a CHEK 52, RAD 51 alone is not sufficient to call it an HRD. Okay, and it is when you're looking at any HRD test, it is important to look at the cutoff. Various tests have various cutoff. The original Myriad had a cutoff of 42. The one which we use at TMH, which has been SOFIA standardized, is again a cutoff of 1. So that's just a bit about the diagnostic, what test to order, germline mutation. And in the frontline setting, you can, if germline is negative, order a somatic mutation and be careful about the cutoffs that you have. So not touching upon low-grade epithelial, I'll just kind of briefly go on to, the advanced epithelial ovarian cancers. We have had a age-old debate on neoadjuvant chemotherapy, but we know still it's presently no difference in outcome with, I'm not going into the trials of neoadjuvant versus adjuvant. We can, for these advanced epithelial ovarian cancers, go ahead with neoadjuvant chemotherapy, interval debulking surgery, and of course followed by adjuvant. So of course there is an upcoming role of HIPEC in interval debulking surgeries setting, and there is definitely a role of PARP inhibitors. So I think what is important to remember is that in the frontline setting, I've listed out all the studies, there is a definite benefit with the use of PARP inhibitors in stage 3, stage 4 high-grade ovarian cancers, especially the ones who are germline BRCA positive. So the ones who are germline BRCA positive, we have an improvement in survival to close to 56 months. And the same is true for their overall survival also. There is an improvement in, trend to improvement. So important to remember is that if you have a stage 3, stage 4 high-grade serous ovarian cancer who is germline negative, HRD negative, there is really no benefit of PARP inhibitors in this patient. So, these are not the ones that we should be subjecting them. Okay, so yeah, this is probably, the kind of broad treatment paradigm, how you would want to treat a high-grade epithelial ovarian cancer. Of course, deciding on what maintenance strategies to use. So do a germline test for them the first time they come to you. Even if, they're not able to do it at that time, at least at the time of interval debulking surgery, do send them for a genetic counseling and testing. And if that comes out negative, then you can do an HRE testing to decide on maintenance PARP inhibitors. If both of them are negative, then of course you think on maintenance bevacizumab. So that's how kind of course there is a small role of use of both bevacizumab and PARP in those who are HR deficient, but we really do not know whether adding two is better than only olaparib. Okay. So I'll quickly move gears to, this was about the upfront setting. In the recurrent setting, there has been this classical teaching of, if after completion of treatment, patient relapses after 6 months, you consider them as platinum sensitive, because as we discussed, because of the HR deficiency, platinum remains the backbone for treatment of epithelial ovarian cancer. But if they have relapsed within 6 months, they were traditionally considered as platinum resistant. But you know what, if a patient relapses after 5.5 months, would you consider them resistant, and 6 months and 1 day sensitive? Probably not, because it's a continuity of care. And therefore, today more and more we are talking about platinum eligible and platinum ineligible. So for patients who are relapsing closer to their 6-month time interval, and they have had a previous response to platinum, or are BRCA mutant, probably somebody who's relapsing at 5.5 months could still be considered platinum eligible, rather than treating them on lines of platinum resistant ovarian cancers. So of course, I'm not going into the fact that if you have a platinum sensitive or a platinum eligible relapsed ovarian cancer, the backbone of treatment is platinum along with another partner. So it could be paclitaxel, gemcitabine, liposomal doxo. But important to remember, like frontline setting, we saw that PARP inhibitor maintenance was for both germline BRCA and HRD. In the recurrent setting, first line recurrent setting, there has been a withdrawn of approval for PARP inhibitors in patients who are only HRD positive without germline BRCA. So that's an important thing to remember, and that is what has come up newly. And the main reason being that when patients relapse after they have been on PARP inhibitors, their sensitivity to further platinum decreases. So therefore, our probably definitions of these platinum sensitivity and resistance would change. And therefore, here you see actually patients who have not received PARP, that is the placebo group, doing better on second line. And that's the very reason why there has not only no improvement, but actually a detriment in survival when people have used PARP inhibitors in frontline setting in the HRD positive without any germline BRCA setting. So that's an important update, and also important to remember that one of the very important side effects of PARP inhibitors is myelodysplastic syndrome, and almost 8% of these patients, that's about 1 in 12, do develop MDS and AML, and even after stopping PARP. So, I mean, this is just to say that, they have been withdrawn. I mean, EMA still continues to approve these. FDA has withdrawn approval. But I think if there is a detriment in overall survival at 8% risk of MDS, so, I think that is there. I would just, complete by saying that, we have a lot of new drugs in the pipeline for these patients with relapsed platinum resistant, which was one of the things which you don't use a platinum, so you use a single agent chemotherapy for these patients. And there are various, treatment options, antibody drug conjugates which have come up. So I think important to remember is that we have immunotherapy, which was till now not approved in ovarian cancers, and previous trials were negative. The current trial of addition of pembrolizumab to weekly paclitaxel has shown an improvement in survival. Of course, there are other newer glucocorticoid receptor antagonists and the folate receptor antagonist. But each of these drugs have a marginal improvement, I mean, even though significant, is like from 3 to 6 months, and each improvement is important, but to keep in mind the toxicity, patient's performance status, costs, And HER2-targeted therapies, which were previously used for breast cancer, have also been used for ovarian. Important to remember is what is the indication. Here they are HER2 3+. Although in breast cancer, even ultra-low HER2 positives benefit from this treatment, but not to forget, the patient, and this is something I really want to highlight, is the time toxicity of treatment. So we know that, a certain drug improves survival by 3 months, 4 months. But if those 3 or 4 months are spent in the hospital, how much time has the patient actually spent at home? So that is something that we need to remember, discuss with our patients whenever we are discussing a newer treatment or a newer therapy. So I think I would, end it there because it will be too rapid for, I suppose, updates on cervical cancer. I think just 2 things is use of neoadjuvant chemotherapy. In cervical cancer, there is a lot, but I think I'll just go to my take home for that. So I think beyond CTRT, we have 2 things we have today in the era of cervical cancer. One is use of neoadjuvant weekly chemotherapy followed by our conventional chemoradiation. That's majority of these patients were stage 2. Exclude patients who had, lymph nodes in the abdomen because they have, and it is important to choose patients correctly because, it is a prolonged treatment. Patients sometimes do get toxicity during the radiation part. So very elderly, frail patient becomes important. And with regards to immunotherapy, the approval is for stage 3 based on the older classification, though our classical stage 3B patients with or without nodes. So if you have an older stage 2B patient with a node positive, so current classification is 3C1. Immunotherapy is not approved for those patients. So I think that's about it. Okay, yeah, thank you.
It's so wonderful, Jaya, as always. And let me tell you, every one of you, that, me and Jaya known each other for decades. And we did our residency also together from All India Institute. We were always next door neighbors and a couple of good memories with long, long years in Tata Memorial also. So Jaya is a very, very cognizant oncologist, and we rate her very, very high as far as the patient care is concerned. And always look forward to hear from Jaya. So thank you, Jaya, for wonderful this thing. And then we will take questions in the panel, I think, Rohini. Yeah. So after panel, we will felicitate everyone. Okay. And thank you, Rohini, for sharing the session. And then you will continue also very soon. Yeah. Thank you.
Now let's move on to panel discussion. The chairpersons would be Dr. Bindu KS. The moderator, I would request Dr. Ranjit Bajpai to come forward. And the panelists we have Dr. Himani Sharma, Dr. Richa Bansal, Dr. Shweta Harwani, Dr. Anita Bajaj, Dr. Deepali Borade, Dr. Jahid Mulani, and Dr. Jaya Ghosh. I request you to come forward on the stage. Ladies and gentlemen, please give a big round of applause.
So good afternoon, everyone. So I see a good number of students over here. So let's hope we'll have a very good summary, and thanks, Jaya, to at least leave it at that cervix. So we'll start with the cervical cancer only. We have panel comprising of both general gynecologists, radiation oncologists, surgeons, radiologists, and of course medical oncologists. So I'll start by just first let's address the first thing which Dr. Gauravi also highlighted in her presentation, that what is the impact of HPV screening. So I'll start with our practicing gynecologists, that how much of an impact HPV, both in terms of HPV screening, vaccination, on to the incidence of cervical cancer.
Hello, am I audible?
Yes.
So definitely if we see in nowadays the screening awareness and awareness about HPV vaccination has increased a lot thanks to the social media and thanks to the awareness done by our doctors colleagues. So even the young girls, they are coming forward, the mothers are coming forward for vaccination, and voluntarily it is happening. And as a part of health check, pap smear has been included for all the women. So definitely screening and HPV vaccination both go hand in hand for early diagnosis and also for early prevention. So definitely they play a big role, and they are. Now the screening age has also been, what I understand, that after 21 years it has to be done every 3 yearly, and with co-testing we are doing every 5 yearly. So girls are aware, and they are coming ahead for voluntarily testing of like for pap smear.
Correct. So I think pap smear screening has been something which has changed the landscape of cervical cancer. I think we all agree on that. As far as HPV vaccination is concerned, Dr. Gauravi also highlighted from the data, recent data, that probably it will take another decade or two to see the full impact of HPV vaccination on the incidence of cervical cancer, although we know that now it is also decreasing. The cervical cancer is going down. So let's see that particularly from the diagnosis point of view, just to continue, or maybe Dr. Anita can take that in terms of once we have a, say for instance, a diagnosis of a cervical cancer and we move on to suggest them the imaging, what you do suggest that would be the gold standard of imaging?
So gold standard wise, MR would come first because the loco-regional spread, MR does fantastically well. The nodes and the spread itself in the loco-regional, so MRI would be the ideal choice. Of course, PET-CT and all come in later stages. Initial stages, any day, it's going to be MRI.
Yeah, because now we know that from 2018 onwards, imaging is has a concrete place in the staging. Jaya also highlighted the fact, and we'll come to that. So of course, when we know that if the lymph nodes are involved, we know that for local extension, for parametrial, I think MRI is still the gold standard. We still await, as far as the MRI, other contrast media for elucidating the lymph nodes, MRI-wise, I think.
Yes, MRI, so parametrial involvement, the lymph nodal involvement, MRI tells fantastically. And of course, the imaging with contrast is important. And it has, imaging-wise also, things are more better as we are evolving. So MRI, I would say, it should be the gold standard. Only if it has spread beyond the local spread, then we go in for PET-CT, but primary imaging any day would be MRI.
Correct, correct. So I'll come to the pathologist. Say, for instance, once we have a biopsy done, do you think that in terms of HPV or other factors which you look for or which help us to decide about the aggressiveness, are there anything which moving in terms of pathology for cervical cancer?
Yes, so for every CA cervix carcinoma, now we do P16, that is to say if it is an HPV associated or it is an HPV independent tumors. That is must for WHO classification of the tumors now, since it will have an impact on the prognosis, like HPV associated will have a better prognosis as compared to HPV independent. Then on the excision specimen, we report like for TNM staging also the size of the tumor, the depth of the stromal invasion. If it is an early stromal invasion, the type of pattern may also help, like Silva pattern, if it is destructive, non-destructive type of pattern of invasion. Then lymphovascular emboli, which we look for. And then of course the extent of the tumor, if it is extending beyond the cervix into the parametrium, into the vaginal cuff which is attached. Lymph nodes are dissected, so on the lymph node status we mention, which will provide the staging of the patient and also the certain high risk determinants, if any, present. So that will guide the further management of the patient.
Correct. So I'll come to our gynec surgeon colleague, Dr. Richa, can highlight that how do we decide. So of course for the early stage, just kindly help us that how do you decide in terms of fertility sparing surgeries or non-fertility sparing, and when is that point where you think that, okay, now probably it's a better case for, say, chemoradiation rather than surgery? Just your opinion, please.
So when it comes to deciding between surgery and chemoradiation, I think the indications for surgery are early stage confined disease, that is stage 1A, stage 1A and stage 1B1 and up to 1B2. That is tumor size preferably less than 4 centimeter size. And of course, when we have ruled out parametrial involvement, either clinically and also with the MRI, ruled out lymph nodal invasion, vaginal involvement. Basically, tumor confined to the cervix with the tumor size less than 4 centimeter size. And on MRI, preferably absence of deep cervical stromal invasion. So the idea is that dual modality treatment should be avoided. Surgery is apt only when we know that most likely radiation will not be required. And the standard surgical treatment is type 3 radical abdominal hysterectomy with the without removal of ovaries, fallopian tubes, but with bilateral pelvic lymph node dissection or sentinel pelvic lymph node dissection, and it has to be an open surgery. Coming to fertility sparing, again, the selection criteria have to be extremely strict. For fertility, again, the woman should be very keen on preserving fertility, foremost. After proper counseling about the risk of recurrence and so on. And about the selection criteria for fertility sparing, first of all, the histopathology, more aggressive histopathological types are not appropriate indication for fertility sparing, like neuroendocrine tumors and gastric type adenocarcinoma, so more apt for squamous cell and probably grade 1, grade 2 adenocarcinoma. Tumor size, most preferable should be less than 2 centimeter size. Of course, absence of perimetrial, vaginal, lymph nodal involvement. Again, ideally a contrast enhanced MRI should be done before. The distance between the cervical tumor and the internal os should be minimum of 1 centimeter so that we can have a clear margin from the internal os while we are doing radical trachelectomy. And of course, the proper lymph nodal staging should be done, and that should be ruled out. Lymph node metastasis should have been ruled out.
Correct. I think probably in radiation oncology, colleague also will agree that when it comes to sparing the ovarian function, there's a clear-cut case of surgery over chemoradiation for early before the parametrial invasion or a bulky cervical stage cancer is concerned. So I think that I would totally agree. I would come to our radiation colleagues, so maybe Dr. Dipali can take. So suppose if we have probably a disease which is more than 4 centimeter, as Dr. Richa mentioned, or the parametrial extension, how would you like to treat? How do you see radiation has evolved over the decades or maybe last few years, where we help these patients more in terms of both not only cure, but also reducing the long-term side effects?
As mentioned by Dr. Richa, the indications of surgery are very clear. So whenever we feel there is no need for multimodality treatment or early stage cervical cancer or young patients, definitely we go ahead with the surgery. But for locally advanced cervical cancers, chemoradiation is the standard treatment. That stage 1B, beyond stage 1B2 to 4A, chemoradiation is the standard treatment. And we are backed by the 18 randomized trials which show that chemoradiation increases the overall survival. And that's why the NCI consensus is also that whenever it is locally advanced, we add concurrent chemotherapy and radiation for the treatment. And in terms of decreasing the side effects of radiation, I think in last 2 decades, we have evolved much technically as well as
with the treatment delivery as well. So image guidance for the radiation therapy, more conformal therapies like intensity modulated radiotherapy, image guided radiotherapy, and also the adaptive radiotherapy or adaptive MRI-based brachytherapy, that's the internal radiation. It definitely has decreased the side effects of the radiation therapy. So what were like in 2 decades back, the radiation was like considered as a very toxic treatment or crude treatment. I think with the advanced technologies, it has changed.
Correct. I'll also take Dr. Mulani. He is also our radiation oncologist from Tata. I'll ask, if you can highlight a little bit more on this question, that what is the importance of brachytherapy when it comes? Because of course, roughly two-thirds of the dose we try to give it with external beam, which covers both the primary as well as the extensions, and also not to forget with the newer embrace and all other guidelines where we try to boost the involved nodes with EBRT. So both you can take. I mean, how much of importance to this?
Yeah. From the beginning of the treatment plan, when you see cervical cancer treatment needs at least around 80 to 85 gray EQD to a gray treatment possible, but that is not possible if we give only external beam radiation therapy because of the OARs, that is organs at risk, which are nearby. It has bladder, rectum, and sigmoid, which are having low threshold values. So in that case, brachytherapy comes into rescue because of two causes. One is that brachytherapy, directly the radiation therapy source can be put in and around the area which we want, the target area, and there is a high dose follow-up. So because of that, we can prevent the radiation fall of doses to the nearby OARs. And also the latest data which is coming from the EMBRACE-2, which is the international guidelines, we are now aware that using the MRI-based image-guided adaptive brachytherapy, we can also reduce the toxicity, and also we are on par with the OS benefit in terms of the trial which the latest come out of the induction chemo trial. So yeah, we are pretty much
Yeah, so correct. So we come to, since you've highlighted, we come to the more controversial aspect, that the interlace trial, which I think just Jaya mentioned about it. So Jaya, please now highlight to that, because you are taking the bread and butter out of the radiation oncologist hand by suggesting that, and you have highlighted a very important point, I think, because the patients who are actually needing the intensification when it comes to radiation, where the lymph nodes are involved, particularly the para-aortics, in those cases were excluded in the interlace trial, which doesn't make sense actually, and I think that's by far the biggest criticism of interlace. And the other important aspect, which I think everyone would agree, in these cervical cancer patients, the total overall treatment time is also a very important factor, which has time and again proved that we have to have completion of the treatment within 56 days. Now, although it is a compressed neoadjuvant setting, a good I would say protocol, but still we know that because of the toxicity, it can still stretch to that overall treatment time, which can be counterproductive in terms of survival. So what is your take? Because we are not willing to give it away, the concurrent chemoradiation basis on this trial.
So what we did is we just, because there was so much of an OS benefit in a randomized trial, so we just piloted out, we just did a pilot of around 50 patients who were fitting exactly into the inclusion. I still don't have the data to kind of complete audit of that, but what we realized is that when you're giving induction chemo, and which is also in the trial, that patient selection is very important, that they should not have para-aortic nodes, because they were the ones who would need extended field RT. And after they have received neoadjuvant chemotherapy, they really don't tolerate that extended field RT. So those patients are excluded. Also, one has to have an RT date. Maybe not so much of a constraint here, but like we have to have RT dates fixed a priori, and back calculate and start, or the day I start the first cycle, we get the radiation dates exactly 7 weeks from the date of start of the chemo, and plus minus 3-4 days, and planning your radiation by week 4 or week 5 of the chemo, so that there has to be a extremely good coordination between the medical and the radiation oncologist, so that everything falls in time. Now, we've had patients who've developed neutropenia after the 6th, or while on CTRT developed neutropenia, and then They've got, but I don't have the exact numbers to give you, and that has kind of delayed. At the same time, there are like the younger, fitter patients with maybe only pelvic nodes, stage 2 disease, 3C1 per se, but clinically stage, the older stage 2B.
Older stage.
So those are the patients who have had a beautiful response to chemo, but then the radiation oncologists were having a challenge as to how much to radiate now, because the whole tumor has kind of shrunk down. So the radiation dose volume was becoming challenging.
I think that way we'll be happy probably, but my main concern was, my main objection to this is the best case, the cases which could have really benefited. So I would look at it this way, and most of the radiation oncologists do have consensus that probably we can take cue of this and use it for proper patient subgroup, because you have highlighted most of those patients which would be best suited for such protocol, wherein you can squeeze this short course of neoadjuvant chemo, particularly para-aortics or particular extension to the bladder, which we know that otherwise could create problem for us as radiation oncologists in terms of late effects, being fistula and all. Probably those are the cases which are best suited for this. I'm sure, I think with the trial which you're doing will help us.
So no, that was not a trial, it was just an audit of, patients who could be incorporated, and we did that. And the other thing was that there were very few stage 3 and 4A, the older 3 and 4A or bulky nodes.
Yeah.
So those kind of patients we really don't know. TMH Varanasi has an ongoing study, so maybe that would answer that.
So we'll move on because there's a lot more. And so I'll quickly skip because Dr. Mulani has briefly touched upon this, that with modern brachytherapy based on Embrace, we have moved on from our conventional 2D, so to say, 2D brachytherapy to much more sophisticated MR-based brachytherapy. So just to touch upon the role of immunotherapy, you of course mentioned very clearly that yes, the newer, as per the newer guideline, not with the low primary burden and just because of the nodal immunotherapy is not the case for that. But still, if you want to have a final comment on that, because Pembro data is quite strong, everyone is jumping guns.
So it is a very important, advancement in terms of overall survival. But, again, we have to look at toxicity. This is a 2-year, treatment with immunotherapy, and that is not easy. Of course, subsequent cycles are 6 weeks. Of course, cost, apart from the cost, toxicity, doing it is also a concern. And of course, patient selection in terms of only 3Bs, the older 3Bs are the ones which were really 3B, 4A are the ones which are involved. So because of this classification, there are many people confused that, 3C1 with the older, like 2B, 3C1s, they are not the ones to be taken for immunotherapy. And most of them were more PD-L1 more than 1%. Now, because 90% of the population is PD-L1 more than 1%, I don't know, and the study is not powered to answer what would happen if PD-L1 is less than 1%. Although approval is for everyone, those are the nuances that we don't know.
Absolutely. So I think I know you have a lot more. Maybe we can skip because I want to come to, and this is one important thing. We'll have quick sort of opinion from Richa as well. So let's come to recurrent disease management. In fact, for all of us who can pitch in, because this is something important. Of course, we have talked about, we have all kind of trials we have had pre-op radiation. That trial was also successful long back, all of things. But let's say that right now the treatment is done with concurrent chemo-RT, and now patient has had recurrence. So Richa, any particular thing, how would you sort of see this thing in terms of like once diagnosis is made for recurrent disease? And if suppose it is in the radiation field only, because of course if it is not in the radiation field, we still have options. So kindly your take, please.
So I think surgical role in a recurrent cervical cancer is extremely limited as well. It would be in a patient, mostly it will be pelvic exentration. I think any surgical treatment which is not as extensive as pelvic exentration, it's again, the survival benefit that it would provide to the patient is really doubtful. So if we are actually looking at a curative surgical treatment, it has to be pelvic exentration. Again, the indications are extremely selective. It has to be a small central recurrence. proven by examination under anesthesia, MRI, again, MRI for the local disease, PET scan should have ruled out metastatic disease. More importantly, patient counseling is extremely important. We have to look at the disease-free interval, the present clinical condition of the patient, how motivated they are to undergo this extensive surgery. I think it's not a straightforward decision, has to be well planned, well thought, and well discussed with the patient.
Correct. So, but at least we have a lot of clarity, because why I've highlighted this, and I thought it was important, because mostly it is considered that once the radiation is done, it becomes a big issue where to touch that in the pelvic area. Of course, pelvic exenteration is quite an extreme option, but at least I was glad to see in the current NCCN guideline also there's a clarity about how to deal with these patients, and it's an important subgroup where the recurrence happens. So I think I'll quickly jump to, because the time would be crucial, I'll skip few of the things. And I think we have discussed most of it, so I'll jump to endometrial cancer now. So please, I think would like you to have back in, and how do you see when you see sort of say postmenopausal bleeding or any bleeding for that matter, and how do you go or deal with patients? And we already have evidence that uterine cancer is on a rise.
Yeah, so usually we see the overall history of the patient. So the risk factors like obesity, hypertension, diabetes, this triad, along with the history of postmenopausal bleeding, the age group, so above 50. So all these factors, they raise the suspicion of endometrial CA, and we get a good transvaginal ultrasound. And the first step is obviously, if we can do a hysteroscopic endometrial biopsy, that is the best option. And depending upon the histopath report, which type of endometrial CA it is, we refer the patient to the gynecologist, and accordingly we go ahead. So that is the initial workup.
Correct. And Dr. Bajaj, I would come to you about the imaging part. Of course, we'll come to molecular later, but just the imaging part, anything else which you would like to add? I mean, you've already highlighted.
With the new equipment, ultrasound to start with tells us if there is, endometrial hyperplasia, what is the thickness, and how is the vascularity. Now we can see how is the RI, resistive indices. A lot of things give us a hint whether this is a normal hyperplasia or this is abnormal or looks malignant, and we suggest histopathological or MRI. The ideal would be, however, an MRI.
Okay.
MRI tells us exactly if it is an endometrial malignancy. If there is any invasion, it is limited, if how much of the muscular layer is involved, if at all, and then, of course, then going beyond what are the, as it advances, if it's an advanced case. And so earlier on, I would say best is do a good transvaginal examination followed by a MRI.
Okay, thanks. So I'll come to the most, I think probably our esteemed pathologist now should pitch in and probably help us, because now it's a practical problem also. I see Prashant also over here, and I remember last week only we had a very detailed discussion about when to send pole and what should be what are the practical barriers for us to have a proper molecular picture, because now we know without the full signature of the tumor, even if before it goes for surgery or sometimes after surgery, how are we dealing with this?
So sir, for every carcinoma endometrium which we get in-house, certain molecular tests we perform on the biopsy itself, like ER, PR, P53 and MMR status. So all these we are performing in-house. The thing is now with the problem is with the fourth subclassification में poly ultra mutated. It is not an IHC test, it requires molecular. So that is not done routinely on every endometrial biopsy. Rest MMR and ER, PR and P53 we do by IHC, and it is done on all the endometrial carcinomas. But poly ultra mutated is not something which is readily available. So, and it is a molecular test which have to be, if the patient is paying, we outsource it. So when that is the, I would say, still a difficult problem to actually classify endometrial as per the molecular classification. And it is not like if the patient is having like MMR deficit, the malignancy will not be an poly ultra mutated. Ideal protocol, it should, every CA endometrium should be tested for poly mutations also. but that is not frequently done since it's a molecular test. So
correct.
that is a challenge for
Yeah.
us.
So we understand that it is the incidence of pole mutations still it's very low in Indian
Yeah.
population and otherwise 5 to 10%, but to my mind I think it's still a very important thing because it helps us to de-escalate treatment and any such decision. I mean, of course we do everything, and so I always feel and I think that this way that there's no point in going half molecular. I mean, we have to figure out the way to get everything on board at the time of pathology final or the at biopsy to be able to take the best possible call for the patient. So I'll come to, after this
Maybe I want to ask Jaya ma'am if in Tata they do poly mutation on every endometrial biopsy.
So we do try to send for all, but I think a very practical thing is, stage till today is the king. So if it is a stage 3 cancer and there are big lymph nodes present, you're not going to de-escalate based on pole. So why waste I mean, especially post-surgery, if you have lymph node positive, so there we really don't need the pole. Whereas, of course, for a stage 1 and 2 cancer, I mean, if you're de-escalating radiation, then even for a P53 wild, one would do a poll to decide on de-escalation. But if you're not a believer of de-escalation, then of course that wouldn't. But I think it is important that for these early stage cancers, we do poly.
Correct.
Because that would help in escalation or de-escalation both ways. So I think that is important.
Correct. So,
Sorry if I can.
yeah, please.
Yeah, so if something like a P53 mutant as well as poly ultra mutated, so by book wise it is like always you prefer a poly ultra mutated, the status you always regard first. So in that case you de-escalate the therapy even if your P53 mutation is there in the early stage cancer?
Basically, the whole concept is because, if you have a good and a bad, good prevails. I mean, that's a philosophical thing. And the other thing is that when you have states like poly or MMR, which, where the DNA is undergoing all sorts of ultra mutations or mutations, then the P53 is a side effect of that. So this is the one which is causing that P53 to look mutated. So if you have a double mutation, then treat it as the good one. So in those cases, I say no chemotherapy and send it to the radiation oncology.
It's Kalyug, it's not good which prevails.
No, it good still prevails.
Really? Okay. So I'll come to Richa. Please highlight that, okay, I mean, we've already had the pertinent points, and of course, early versus delayed, if lymph nodes involved, everything changes. So how do you see now, with all molecular and imaging, of course, she has highlighted, how do you see the surgical management of this? Because we know this is the first step.
Yeah, so I think tailoring our surgical treatment or modifying our surgical steps as per the molecular classification is extremely important. In my practice, and I think that is what the evidence also says, that if it's a P53 mutant tumor, so if it's standard ER/PR positive and MMR deficient and early stage, the standard treatment will be minimally invasive surgery with sentinel lymph node. But if it's a P53 mutant tumor, we are not preferring MIS and generally prefer an open surgery with more extensive lymph nodal staging, peritoneal staging, momentum, etc. I think this is where the molecular classification is extremely important to us as surgeons for our surgical planning, and of course for subsequent adjuvant planning, definitely.
Correct. So let's see, and this question also, you have already mentioned, okay, para-aortic, and so anything for fertility sparing in these cases, the same thing what you've mentioned
Yes,
about?
so again, for fertility sparing treatment as well, molecular classification is extremely important to be done. Fertility sparing is, the ideal candidate should be ER/PR positive, P53 negative. MMR, is still a controversy. So if MMR deficient, then these patients are thought to respond to medical management less. So that should be well explained. And of course, Lynch syndrome has to be ruled out.
Correct.
So ideal candidate would be a young patient who wishes to preserve her fertility and who has early low-grade disease, ideally confined to the endometrium on MRI, but less than half myometrial invasion with a few selected individualization can be done. And of course, lymph nodes, ovarian involvement, all that must be ruled out with the MRI.
Correct. I come to Dr. Dipali now. Let's see what has happened with molecular risk stratification. Now we have PORTEC 4A published as well, and probably which will change the practice. So what is your take now with adjuvant radiation, how it has changed?
So for adjuvant radiation therapy, as rightly said, molecular classification helps for early stage disease where the decision is whether to give radiation or no. So mainly in the high intermediate stage where the confusion is more. In that case, whenever these molecular factors like P53 is positive, though it's like grade 1 or grade 2, we can escalate our treatment. And whenever it is POL-E mutated, that time, despite of grade 3, we can de-escalate the treatment. That's how the radiotherapy treatment has changed considering the molecular classification.
Correct. Dr. Mulani, you want to add few more things, I mean, with PORTEC, how it has developed, how it has changed, particularly say for instance a case which is otherwise say restricted, but maybe say a high grade tumor, a variety which is more putting into straight away into stage 2C. So how do you deal usually in a routine practice?
The routine practice now, because of this PORTEC trials, the molecular testing has become very important. So I generally routinely send all of my patients for the molecular testing. And based on what we have seen, that if the POL-E ultramutated is there, then we can de-escalate the treatment safely without having any rule of adjuvant treatment in that cases. If the patient is having NSMP status, then accordingly we will have to say whether the patient is of low grade ER positive or high grade with ER negativity. In that case, we can go ahead with the vaginal brachytherapy alone. And if P53 mutated is there, then we have to do a full panel starting from the EBRT with concurrent chemotherapy followed by adjuvant chemoradiation.
Yeah. And just a correction, I think PORTEC 4 is already there. So I think. So I come to Dr. Jaya now that, okay, you already answered. So with all this, what has changed as far as the systemic therapy? Let's see about the sandwiching or whatever your other agents.
So, I mean, what has changed is that for an early stage endometrium confined disease, our indication to give chemotherapy is if they are P53 mutated without, of course, POL or MMR. And the other, what has come up is a new thing which is in the current thing is the NSMP ER negative subgroup. So P53 wild but ER negative, they are sometimes a very bad biology or a bad, so like the mesonephric type. So that's a very aggressive cancer. So just P53 wild should not make us think that, okay, it's a good cancer. So if we get a P53 wild and ER is negative, that's when our pathologists start doing GATA3 and other tests to rule out these high-grade cancers. So that is another group, if these are those specific high-grade histopathology types. So they are the other ones where one would want to give adjuvant chemotherapy and chemoradiation. We do follow the PORTEC 3 where, but we follow it in the other order. We give the 4 chemotherapy first, followed by chemoradiation. So 4 Paclitaxel followed by CTRT, but I mean, I completely agree with the original protocol, but there are studies retrospective to show that really the sequence does not matter so much. And for something like a high-grade serous, I would probably go ahead with this. But for a clear cell with maybe lower uterine segment, we might want to reverse the order. So that the order really does not matter, but that is how we would do it. In terms of stage 3 disease, what has new come up is the use of immunotherapy.
Correct.
In addition to chemo in these settings, and that is for a period of 1 year. In an MMR deficient stage 3 cancer, what we still don't know and what the rainbow will tell us is whether chemo is at all needed in these or not. But as of today, it is chemo-RT and immunotherapy for a period of 1 year for an MMR deficient stage 3 cancer. So,
okay. I think I'll skip because otherwise. So, and few more quick points on any of these which you want to cover.
So, the thing is that when you have a first line, I mean, if we have a patient who's upfront metastatic, those patients we prefer a combination of chemo plus immunotherapy. I mean, it can be either pembro or dostarli. Once a patient has relapsed after use of only chemo or has relapsed very early after the chemotherapy, those patients we do use a combination of pembrolizumab and lenvatinib. Now, but if a patient is MMR deficient, then rarely if you look at the two data, there is hardly anything benefit we are getting with the addition of MMR, with the addition of lenvatinib. So if in a first line recurrent setting who's relapsed after say a paclicarbo within 6 months, or those patients if they're and they have not received IO earlier, I would use single agent pembrolizumab. If the patient is MMR proficient, we would use pembro plus lenva. And another thing in this setting is also do look for HER2 in high-grade serous, because there is data for use of trastuzumab with paclicarbo. So look at MMR and look at also ER/PR HER2. And also remembering that, sometimes we are so driven by the immunotherapy. So if it is a grade 2, ER positive, P53 wild, MMR proficient tumor which has 2 Chintu lung nodules or, some small nodes, you don't need to bombard them with chemo, immuno. You can just put them on some hormones, So we have to, so the MMR proficient is a very heterogeneous group. So we can't club everything and treat everything in the same way. So I think we are learning more on that.
Yeah, I think I agree. So yeah, so I take back a little bit of my euphoria about molecular, and you have actually driven home very good points that it's just not only molecular, a lot of other factors which needs to be considered before we take the final call. I'll come to the last bit, and which is, of course, I mean, this is the summary. I'll come to the last bit. Of course, I mean, the recurrences and what do we see in long term. So, I mean, of course, gynecologists are the ones who see these patients after finishing the treatment coming. So have you encountered few of the key issues which you would like to highlight, or something which we can have a bridge so that these patients, when they're coming up for follow-up, gets benefited? So, like say for instance, vaginal issues, all those things,
so,
please.
like most of the patients after brachytherapy, they come with vaginal stenosis, dyspareunia, and sometimes recurrent infection. Then
Sorry about that. Yeah, please.
So most of the patient, they comes with vaginal stenosis, dyspareunia, and there is discharge also after radiotherapy. And then recurrent urinary infections. So basically local genital irritation, burning, all these local symptoms are most, and then sometimes pigmentation. So these are the most worrisome symptoms.
But I hope you have seen improvements in these side effects over the years.
Yes.
I mean, that is something really important, because earlier the way we used to treat it was, I mean, pigmentation, as you said, even subcutaneous fibrosis, all those things are now things of past.
Yeah, so that's why I said pigmentation last. Very rarely we see that.
And I just wanted to highlight for the sake of students, basically.
So mostly it is basically stenosis features or dryness, irritation.
Okay. Anything on hormonal side or anything, of course, hormone?
Most of the time, see, either hormone, they don't have too much of, they present at an age when it is already the menopause has set in, or if the fertility preservation surgeries have been done or sparing surgeries, and they have been supplemented with HRT, depending upon the ER/PR status and everything.
Correct.
So they have been taken care very well by the whole multidisciplinary team.
Fair
So
enough.
most of the time, they don't have much of the side effects of this.
Correct.
But those who are on tamoxifen or letrozole, like then these patients, but they are separate actually. For breast CA, we see a lot of patients. They have thickening of the endometrium. They are worried about whether it is because of the side effect of the medicine or whether it is CA. So these are the group of patients they are worried about.
And Dr. Dipali, anything in particular for these patients on follow-up which you do to help these patients out?
Yes, as ma'am's role in stenosis and other things, that's why it is very important to counsel these patients regarding the side effects. And when we use advanced technique, most of the side effects are reduced. But stenosis definitely a post-brachytherapy if the vaginal dilator exercises are not given. So for every patient, they must follow and they should do the exercises, whatever explained to them. So we have seen now, so we do brachytherapy. So nowadays we don't get the stenosis or fibrosis since the patient are using proper vaginal dilator better exercises. Plus, it depends upon the routine habits. Whenever we have given radiation, we generally tell them they should avoid the constipation. They should hydrate themselves so that the late side effects of radiation therapies like proctitis and cystitis can be avoided.
I think we agree as a radiation oncologist most of the times now proctitis and cystitis
Yeah,
is something which we have really reduced to a significant extent. Those were really important.
Yes, during cobalt era, that was the main side effects of radiation therapy. Correct. But nowadays we don't see that.
Correct. And of course, we have seen this, the huge benefit of teamwork. I mean, it's not about just surgeons or pathologists or gynecologists or radiation. I mean, it's a teamwork which really helps patients to, the good prevail, I take from Jaya, the good prevails eventually. So thank you so much. I hope it was beneficial for all. Any other question? I mean, I see students, so I think everyone has covered phenomenally well, everything, most of the, yeah, please.
Jaya ma'am, I have a question for you. So if a patient, there is a subset of patients who are HRD negative and germline BRCA negative. So yeah, for ovarian cancer. So where do you see the use of niraparib in those subset of patients?
I think ovarian is coming right now. Ovarian will be coming. Ovarian, there's a discussion, yeah. Okay. So I think we will not dilute. If on cervix endometrial, please, ovarian, just hold on. Yeah.
So thank you very much for a wonderful moderation and wonderful participation.
Thank you, everyone.
From all and.
Thank you so much, everyone. I would request Dr. Jyoti to come forward and felicitate Dr. Jaya Ghosh. Please give a big round of applause, everyone. I would request Yes. I request Dr. Richa Bansal to felicitate Dr. Rohini Kulkarni. Please give a big round of applause, everyone. Now I request Dr. Rohini to felicitate Dr. Bindu. Okay. I request Dr. Rohini Kulkarni to felicitate Dr. Ranjit Bajpai. Okay. Dr. Ranjit Bajpai, I would request you to felicitate Dr. Himani. I request Dr. Himani to felicitate Dr. Richa Bansal. Dr. Richa, I request you to felicitate Dr. Jahid Mulani. I request Dr. Jahid to felicitate Dr. Dipali. Dr. Dipali, I would request you to felicitate Dr. Shweta Harwani. Ladies and gentlemen, please give a big round of applause. Yes. Dr. Shweta, I would request you to felicitate Dr. Anita Bajaj. Ladies and gentlemen, please give a huge round of applause. Now let's move on to the final panel discussion, Shifting Paradigm in Management of Ovarian Cancers. I would invite the chairperson, Dr. Jyoti Bajpai, on the stage. Sure, no problem, ma'am. We have Dr. Rohini Kulkarni as the moderator, and we have the panelists, Dr. Anand Zade, Dr. Bindu, Dr. Veena Vanare, Dr. Prashant Nyati. Please give a big round of applause. I request Dr. Jaya to join us on the stage.
So in the interest of time, we will request everyone to be very quick and to the point for the comments.
Good evening, everybody. So at the outset, I would really like to thank Jyoti Madam and the organizers for inviting me. Apologies from Dr. Amita Maheshwari, she couldn't be here due to some emergent commitments. So without wasting any time, if we can start off with our panel discussion. So this is going to be a case-based panel discussion in which we have this one case of a 35-year-old lady who has been married for 3 years, nulliparous, history of infertility treatment with ovulation induction, and history of breast cancer in mother. She presented to her gynecologist with complaints of abdominal distension and bloating. And on examination, she was of good performance status with no lymphadenopathy. However, abdomen showed moderate free fluid with a mass of 5 into 5 centimeters with restricted mobility. And same mass was felt through the fornix with no POD deposit. So how would we evaluate? If Prashant sir could take the question. Yes, sir. So yeah, we would do that. Right, I agree with you, sir. So basically how we would evaluate is with tumor markers, which include CEA, CA125, CA99, and also the germ cell markers because she is 35 years of age. And since she had complaints of infertility treatment as well, we routinely follow doing a serum AMH and an ultrasound abdomen and pelvis. She actually came to us with these investigations. So just to highlight how to triage a patient who comes to us with a complex adnexal mass and features which may be suggestive of malignancy, we have multiple indices to check on ultrasound. One is if Anand sir can highlight a little bit about it.
So initial imaging modality is going to be ultrasound. That will help us to characterize the lesion. And we usually use the ORAD's scoring. And depending upon the ORAD score, we know the probability of it being malignant. Since its case of patient is nulliparous, she's planning for pregnancy, and in case we are thinking it's a borderline lesion, then MRI is going to definitely be the imaging modality of choice. So based on the ORAD score, we know what is the probability, and again we correlate with the tumor markers before taking it forward.
Right. All right, so thank you so much. So again, comparing all the risk scoring systems, IOTA, ADNEX model and ORADS models are the ones which really give us a predictability of what chances are there for it to be a malignancy. And they have very good sensitivity of over 90%. So these are some of the characteristics of the same. We have simple rules as well as ADNEX model. ADNEX model has a better sensitivity and a better specificity. However, it does require an app and other paraphernalia which might not be available with everyone. So the next point was that this patient upfront, when she presented, it was a complex adnexal mass, there was ascites, and CA125 was in the range of 2000s. So she was very anxious and concerned about her further fertility. And she wanted to know what the scope of any fertility preservation is, even before a biopsy or even before any histopathological diagnosis. So how would we counsel her for fertility, regarding fertility management, and what is the role of fertility preservation in ovarian neoplasms? Which neoplasms can we preserve the fertility in, sir? If Prashant sir can take the.
So first of all, we need to check the AMH levels, where she stands currently. Second thing is we have to counsel from the start that we need to identify what sort of tumor, then only fertility preservation is possible. So borderline tumors or germ cell yolk sac, those type of tumors, yes, definitely. Or even if it is a epithelial ovarian tumor 1A grade 1, which is limited to only ovary, then you can consider for fertility preservation. Anything other than that, anything high grade tumors going outside, then we will have to counsel the negative way. Most important is to identify where we stand first. Like as you told, she had ascites, so we need to investigate, we need to check whether it has gone outside. We need to, like if MRI, upper abdomen, if there are any nodules, any spread, we have to check complete. And then next step is we'll have to investigate further.
Right. I completely agree with sir. Borderline tumors, germ cell tumors, and a few sex-cord tumors and low-grade epithelial ovarian carcinomas, which are very early stage, 1A or 1C1 are the only ones which are amenable for fertility preservation. So now, if the CA125 is 2000, the rest of the tumor markers were normal, what imaging would we prefer?
In this case, since we know patient has got ascites, most probably we'll do cytology, and we know probability of it being a malignant ascites is very high. So the imaging modality of choice in such case would be PET-CT, because routinely what we are doing is the PET-CT scan with a diagnostic CT. So all the information which a routine contrast enhanced CT scan gives, a PET-CT scan definitely gives. So PET scan will have a higher sensitivity when it comes to extra-abdominal disease, like epiphrenic nodes, supraclavian nodes, or any pulmonary mets. So FDG has a higher sensitivity, and considering the cost is also, availability is also not a challenge today, so PET-CT would be the imaging modality of choice.
Right. So I think each institute has its own protocol. Jaya ma'am?
Yeah, I think it's just that in the upfront setting for a suspected ovarian cancer, really probably a good contrast CT of the thorax, abdomen and pelvis would also give us an equivalent information. And some of the difficulties or challenges that we face with PET-CT is picking up of mediastinal nodes, and then you keep chasing that mediastinal node to understand whether it is inflammatory or metastatic.
Yeah, I agree, because our institutional protocol would be to go ahead with a contrast enhanced CT
Especially
scan.
when we are suspecting mucinous, we would like to rule out whether it is a Krukenberg's or no. So the most commonly imaging modality for staging is CECT. If you want to characterize the ovarian masses, then definitely PET-CT is not the modality. We'll have to rely on either ultrasound or MRI.
So clinically, sir, where would you use MRI? Where would you use PET or CT in case of an ovarian complex adnexal mass?
So MRI, we will always, like when you have 5 centimeters, somewhere that range, where you need to identify where exactly, whether it is solid cystic areas, what component, or many a times like 35 years endometriotic patches. So whether it is an endometriotic cyst, where you need to identify, we will go for the MRI. But when you need to, like if ascites is there clearly, then we would like to go in, because subdiaphragmatic deposits, nodules, peritoneal diseases, all things are better, lymph nodes, with a CT. So that cases we will go for a CT scan.
Right. So I think as of now, all our consensus is for an advanced disease, mostly a CT scan in the upfront setting, PET CT sometimes, but depending on the histology, and MRI to characterize the lesion for an early disease. So this is her CCT, thorax, abdomen, and pelvis. So if we can see the images, there were bilateral adnexal masses, moderate ascites, peritoneal nodules, omental fat stranding, nodularity, enlarged retroperitoneal lymph nodes of about 1.6 centimeters. However, thorax was clear. So, so next step, I assume, would be to go for a biopsy or tapping of the fluid. So, madam, what would you prefer, getting a biopsy or a cell block? Is there any technical challenges that you face with either?
So, of course, biopsy is definitely the specimen of choice in this case, because with the biopsy we can do some many additional tests, like further IHC testing, even some molecular testings also we can do. Cytological cell block will be a limited material, because there will be a lot of contamination with the inflammatory cells. So biopsy is definitely a specimen of choice for this case.
Okay. So usually what happens in busy OPDs is the patient comes with distress. We tap the ascitic fluid and then we end up sending it for cell block. So is it possible for us to perform other additional tests such as HRD or other tests if may be required on a cell block?
Of course we can do them, but there are limited challenges for that.
Okay. So biopsy would be the preferable.
Biopsies are definitely preferred.
So at this point of time, when we do a cell block and we've already got a diagnosis on that, the question would be whether to subject her for another biopsy at this point of time or wait for the surgical specimen to do these additional tests. That would be the next challenge that we face. So especially HRD, considering we're dealing with ovarian cancer, is a post-chemotherapy surgical specimen good enough for HRD testing?
So in that also we have to pictographically analyze all the tissue sections, and we have to provide the best possible tissue block for where there is a maximum number of viable tissue cells, because there will be definitely a lot of necrosis because of the post-chemo changes, and there will be some changes due to the treatment also in the so the tissue specimen or the block where there is maximum viable tissue should be preferred for further testing.
Right. So we do have challenges for a post-NACT setting where we might not find some tumor sometimes. So these were this was the reports of the patient. 2,200 was CA125. Ascitic fluid cell block was high-grade serous carcinoma. So considering the age of the patient, madam, she is a 35-year-old nulliparous woman. The chances of it being a low-grade carcinoma is probably quite high. So if you can enlighten us about how we differentiate high-grade from low-grade serous carcinomas and nuances in the interpretation of P53 mutations.
So high-grade and low-grade serous carcinomas are divided into morphological or the cellular level, and also on the genetic front. So high-grade serous carcinomas are very cellular. They have very lot of nuclear abnormalities, like nuclear morphology is very much variable. They are very highly mitotic tumors, and they show a lot of necrosis. Whereas the low-grade tumors on morphology, they are resembling the normal cellular makeup, and they are mitotically not very high, and they show no necrosis. So this was on the morphology.
On the genetic front, high-grade serous carcinomas are universally p53 driven tumors. They are also associated with BRCA1 and BRCA2 mutations, whereas low-grade serous carcinomas they lack TP53 mutations, and they are usually associated with BRAF and KRAS kind of a pathway. So that is how the molecular differentiation between high-grade and low-grade carcinomas. Coming to TP53 pathway, so we are not just limited to identify on IHC whether it is P53 positive or negative. We have to definitely identify whether it is aberrant expression or a wild expression. Aberrant expression is defined as maybe a strong diffuse positivity of more than 60 to 80% of tumor cells, or a null type. Second category is a null type, and third type is a cytoplasmic of membranous staining pattern. And the wild type is usually, so these all patterns are seen usually in high-grade serous carcinomas where there is TP53 mutations. Low-grade serous carcinomas are usually wild type, so they show a heterogeneous kind of expression with P53 IHC staining.
Completely agree with you, madam. So P53 was mutant in this particular case. Also, to add on to it, ER and PR were also negative, which usually tend to be positive in low-grade carcinomas. So, are there any additional tests we would want to run at this point of time? Anybody can take. Jaya, madam. Yeah, so I think you already highlighted in your previous talk that we first go in for germline testing and then consider the HRD testing after that. That was one of my questions. So that has been already addressed. So I think Jaya madam has already covered all this regarding HRD and how HRR is not the same as HRD. And Myriad My Choice is one of the standards, and Sophia is the one we use at our institute. So in this particular patient, germline testing had come positive with a BRCA1 pathological mutant gene. So next we would go in for the surgical management. Sir, how do you choose, what would your choice in this particular case would be?
Since they are para-aortic lymph nodes, always peritoneal deposits. So in this case, we would go for NACT versus primary surgery.
Okay. All right. So, so there have been multiple studies with respect to NACT versus primary surgery. It all started with the study by Bristow et al., who said that primary surgery was better than interval debulking surgery with respect to survival, and as long as the patient can tolerate a primary surgery, that would be the best way to go. So after this, a host of trials have been carried out, the predominant ones being CHORUS, EORTC trial, a meta-analysis of that JCOG trial, and also the SCORPION trial, which was predominantly high volume disease in which primary debulking surgery versus NACT was compared. And in majority of the trials, we saw that NACT IDS was non-inferior to primary debulking surgery. And most recent is the TRUST trial, which was a multi-center RCT, which included high-volume expert ovarian cancer centers with predefined surgical quality criteria. And close to 700 patients were randomized. Their primary outcome was the median OS, where it was not statistically significant between the two groups. However, if we can see that the PFS was statistically significant. The difference in median OS between both the groups was close to about 6 months. However, in their subgroup analysis, they also showed that patients who had a complete resection after primary cytoreductive surgery, median OS was 67 months, which was largely different. So the author's conclusion was that although it did not meet the primary endpoint, it did show a significant improvement in progression-free survival, and also there was a clinical benefit in overall survival. So they concluded that patients who are fit and have disease which is completely resectable should be advised primary debulking surgery. This is an institutional practice differing from surgeon to surgeon. So as long as we are achieving a complete debulking, I think the mode of upfront versus NACT and IDS should be chosen carefully. So she underwent neoadjuvant chemotherapy, and after that she got a good clinical response. Her CA-125 dropped to close to 40, and the CT scan showed significant improvement. And we offered her interval debulking surgery. And here, if we can see, all the nodes had become subcentimetric. So, sir, what is your take on addressing all the lymph nodes in this during surgery?
So, see, it depends on the pre-chemo status of the lymph node. So, there are trials, the Lyon trial, and which has stated that in cases of debulking surgeries, you can skip the lymph node also because the morbidities and the survival is not much difference. But what we go with prior to surgery, chemotherapy, if they are bulky nodes, we would like to address them so that if microscopic deposits are there, we will definitely try to.
Right, sir. I completely agree with you. Where we look into the pre-chemo CT scan, identify the nodes which were enlarged, at least address them by opening the retroperitoneal spaces during the surgery, and if they are enlarged, debulk them. But a systematic lymphadenectomy does not add to any survival benefit, although they had found close to 57% of the patients had micromets on systematic lymphadenectomy. It did not translate to survival benefit. What about HIPEC?
In this case, since BRCA is positive, as you already suggested, young patients, I normally divide the patient with the PCI scoring prior to and after also. Second thing is, with the advent of BRCA and olaparib, if you can give olaparib, yes, definitely then HIPEC can be skipped. But if primary pre-chemo, the PCI score is more, primary she had more of peritoneal disease, then you can consider HIPEC in those cases.
Okay, all right. So, any thoughts on evidence regarding upfront versus interval?
So upfront, there is still under trial. You don't have any evidence for upfront HIPEC. Yes, for interval debulking and secondary, there are HIPEC evidences.
Right. So I agree with you, sir. HIPEC is predominantly for interval debulking setting. There are two trials which support it. One which investigated it only in interval debulking setting, and the other one where the benefit was seen only when HIPEC was performed during interval debulking setting. One is OV HIPEC 1 and other one is the Limetol. Although both of them do have their criticisms, pros and cons, largely there are two meta-analysis also, one in 2022 and one in 2025, which has shown that HIPEC is beneficial in interval debulking setting only, and no benefit has been seen in the recurrent setting or primary setting as of now.
Most important is you should remember HIPEC is not an alternative to incomplete CRS.
Yeah,
so
exactly.
if you have a
completely
R0
agree.
resection, then only
HIPEC is,
you should go for
yes.
HIPEC in those cases.
Yes, that's a very prudent point. So we also have a trial running in our institute in which we have 3 arms, control, HIPEC and NIPEC with cisplatin and doxorubicin. So what drug do you use, sir, usually, and what dosage?
So normally cisplatin single or cisplatin with adriamycin, and cisplatin is body surface area, so either 80 or 90, it will be depends on the body surface area, and adriamycin, so normally it is for 90 minutes, so we follow one of Italian this thing in which cisplatin we give for 90 minutes and adriamycin for 40 minutes, and that is 9 milligram per meter square of adriamycin.
Okay, all right. So she underwent IDS and HIPEC with cisplatin 75 milligrams per square meter and doxorubicin 15 milligrams per square meter for 90 minutes with us. So what about adjuvant treatment, madam?
No, this patient has had upfront CC0, an optimal cytoreduction. She's BRCA mutant. I would give her only PARP inhibitors. I mean, so I wouldn't add bevacizumab to it because we don't know whether bevacizumab actually adds anything to this. In your POLA, the control arm was only Bev was compared to Bev plus OLA, but Bev plus OLA has not been compared to OLA alone. So, I mean, there's an ongoing study, but I think till we get the results, I would put her on single agent PARP inhibitor maintenance for 2 years. And it is important, like since some of the students are here, that you should start the PARP inhibitor at least after 1 month after completion of chemo. If you started on day 15, then you know the counts crash. So it is important that we wait for full count recovery, then start and monitor them closely because some of the patients, it's not that, if on day 8 their CBC is normal, everything is going to fine and I just call them after 3 months. You have to, in the initial 3 to 4 months, monitor them initially weekly or then 10 to 15 days, because we've seen patients come back on, after 2 months, because we thought till 1 month we followed and sent them off, and then they come after 1 month with a hemoglobin of 4 or 6. So it is important, to monitor them, inform them about the symptoms, because low blood counts, especially low hemoglobin, fatigue is an important component. Sometimes patients' counts are normal, but fatigue affects their day-to-day life, like something as simple as, lifting a water jug. So that may not account there, but actually one patient did mention this as significant fatigue for that. So, those are, and this is not a 1-day treatment or a 6-month treatment. It is going to be a 2-year treatment. So it is important. And another thing, especially not so much in the upfront setting, but in the recurrent setting, if they keep having low counts, then you do need to think of MDS or AML, and send peripheral blood. Of course, first check the nutritional profile, correct the nutritional profile, but also be on a watch out of MDS, AML, especially, if they keep coming back with low count with no other cause, even after dose reduction.
Thank you, ma'am. Ma'am, any alternative practices, any other thoughts that you would want to share? Okay. So, in whom would you prefer bevacizumab, ma'am?
I would prefer bevacizumab, especially if they are BRCA negative, germline BRCA negative, HRD negative, and especially if they've not, they are stage 4 disease, or they have had stage suboptimal debulking surgery. So those are the patients we would prefer bevacizumab. There is a small role in patients who are HRD positive but germline BRCA negative, but there again, as I mentioned, that I don't know how much bev is adding, but strictly speaking, the approval is there for olaparib plus bevacizumab, and if you have to use only single agent PARP, then as per strict guidelines, that is for rucaparib. So although we do use a lot of this exchangeably, but that is the subgroup that I would use bevacizumab.
Right, ma'am. So GOG 218, ICON 7, predominantly what you mentioned are the set of patients who benefited. So this is just a summary table. All PARP inhibitors fared better with HRD or BRCA mutants than HRP or unknown BRCA status. Yeah, ma'am.
Okay, so in the ICON 8, I mean, we were very skeptical of use of bevacizumab, but in the ICON 8, the last arm with bevacizumab has actually used bevacizumab in the neoadjuvant setting, but and there are 2 other smaller trials with use of bev. So I practically do not use bev in the neoadjuvant setting, and some of the challenges that we face is because one is I need time to know, am I going to use bev in the long term for this patient, or am I going to put her on PARP? So giving neoadjuvant just paclitaxel gives time for germline testing and NGS. And sometimes what the challenge that we face in giving neoadjuvant bevacizumab is that you anyways are able to give it for only 2 cycles and you have to stop. And occasionally these patients are quite thrombogenic, so thromboembolism, or if they have extensive peritoneal and bowel involvement, there is a chance of perforation. So those are the challenges. Of course, it's not, if somebody decides to give it, that's fine, but we personally do not give it because of these reasons. And I take the decision for bev more after the surgery, and by which time I've already known what kind of surgery the patient has undergone. Although both the GOG and the 218 were patients who had undergone upfront surgery. They were not in the adjuvant. It's only in the ICON 8 that we have the use of neoadjuvant bev. So that is what.
Ma'am, so just your opinion about immunotherapy?
Okay, Duo, yes, there is there, and mainly for patient who are maybe an option in a patient who is HR proficient, but presently haven't used the Duo setting in that. Because, if you use all your guns upfront, I don't know how much benefit we still need, the full data on this and for some marginal benefits. So I think it is still evolving, and maybe we need to know more.
So, yeah. Bev. Right. Time for surgical intervention. Right. Agree with you, ma'am. So this patient did not, due to financial reasons, did not opt for PARP inhibitors. She had a disease-free interval of 17 months, after which she recurred. CA125 was it was low, it was not very high, and she had very limited disease, just circumferential wall thickening at the rectosigmoid, but it was biopsy proven to be high-grade serous carcinoma, and there was a serosal deposit at that level. So what about secondary CRS, sir?
So here in this case, I would definitely ask for a PET scan also,
Okay.
just to know the extent of disease,
Right.
whether it is just limited to that place or any other, because if we are going in for a surgical resection, I need to know that. And yes, definitely, if single site recurrence, then definitely cytoreductive surgery is a good option in this case.
So any additional comments about? Yeah, so I think in a recurrent setting, PET would definitely be very useful. Regarding selection, what are your selection criteria for secondary cytoreduction, sir?
Limited volume disease is the main criteria. General health should be good, and disease-free interval should be at least more than 6 months. So we would like to go.
So you wouldn't operate on a peritoneal carcinomatosis in the secondary setting?
Peritoneal carcinomatosis, if the disease-free interval again is good, then we will consider. Then there comes the stage of CRS and peritonectomy and HIPEC. Those all things will be considered. Again, there is a role of newer thing, that is PIPEC in these cases, because it depends on the extent of PCI score. So though it is experimental, yes, we can use PIPEC, or we can go in for only peritoneal carcinomatosis, other than like bowel involvement, all those things we will have to consider. So those come into picture.
PIPEC predominantly in the platinum resistant refractory setting.
Refractory settings.
Yeah, where we have exhausted all our armamentarium. So in this, we have multiple trials about secondary cytoreduction. I will not go into the details. Basically, a very well-selected group of patients in which we can achieve a complete cytoreduction. That is the premise of all surgeries. So this has shown that when no gross residual disease was achieved in meta-analysis of secondary cytoreductions, there was significant benefit in survival. So basically this patient was offered secondary CRS, she was not keen, she completed 6 cycles, and then she agreed for secondary cytoreductive. We did an anterior resection and peritonectomy. So in this particular case, HIPEC, if not done in the first setting.
Yeah, but still I wouldn't go in for a HIPEC in this case, because already it is just limited volume disease. HIPEC will more benefit of peritoneal if there are gross deposits which you have already resected, or if it's like olaparib, as you already said, she is not for financial reason. So localized good excision with R0 resection, it's sufficient.
Okay. All right, sir. So quickly brushing through, CHIPOR was a negative trial, CHIPOR was a positive trial, but the trial design was that patients receive 6 cycles of chemotherapy at recurrent setting in a platinum-sensitive recurrence, and then undergo cytoreduction and HIPEC. However, HORSE was a negative trial in which they underwent HIPEC at upfront setting in recurrence, as in before chemotherapy in recurrence. It did not meet its primary endpoint, that is progression-free survival. However, 5-year post-recurrent survival was good, but despite that, there is a meta-analysis also showing that there is not much benefit, so we still have to await good data to recommend the same. So ma'am, quickly, if I can just ask you some 2-3 points about chemotherapy or systemic therapy in recurrence. In a platinum-sensitive setting, what would be your choice? In platinum-resistant disease, what would be your choice?
So platinum sensitive or platinum eligible, as I may put it, would be a platinum-based doublet. I mean, platinum with either paclitaxel or liposomal doxo or gemcitabine based on the previous toxicities. And if somebody is like within 6 to 12 months, then maybe preferable to use a liposomal doxorubicin and carboplatin. Patients who relapse closer to the 6 months interval, I mean, based on the Calypso. So that's there. For a platinum resistant setting, one has to look at the performance status, single agent chemotherapy, and of course, nowadays we have the option of adding immunotherapy to weekly paclitaxel. But we have to also keep in mind overall patient performance status, and yes, role of HER2/neu testing for understanding the role of TDXT and folate receptor alpha, but it should be more than 75%, moderate staining for it to be called positive. Because the drug is not available in India, of course it can be imported, but that is an option in these settings. Important to remember this mirvetuximab has a lot of keratitis, and patients actually need to be on steroid drops. So, that's an important side effect. If a patient has blurring of vision and keratitis in a platinum resistant setting, that would significantly impair their quality of life. So, I mean, it has definitely a benefit, but side effects as well. So, those are the things we need to keep in mind. And of course, we use a lot of oral metronomic or low-dose cyclophosphamide. That is something that we use.
So, ma'am, considering trastuzumab deruxtecan is not really available that...
No, deruxtecan is available. TDXT cost is, of course, there. It's about close to 300,000, 3 lakh rupees per cycle, 3.6 approximately. With patient assistance program, I think it comes down less.
So is there any role of just giving trastuzumab?
We do not really know. I mean, we have more data in endometrium than for ovarian. Probably that's what we need to do, but
yeah. Sorry.
HER2 testing.
Right. Okay. Thank you.
One point I wanted to ask, ma'am, Jaya ma'am, like HER2 testing overexpression, is it like more seen in mucinous and clear cells than the serous subtypes? Is it like in the clinical practice?
We currently have started doing HER2 and serous recently because of the approval for these TDXT. But yes, clear cell and mucinous are the other things where HER2 are positive. And for clear cell, actually there is some data on use of immunotherapy as well. And, one positive and one negative trial. But yeah, there's an evolving data of use of immuno in clear cell on lines similar to renal clear cell. So that is there. But yes, those are the other ones where we do, and sometimes at least in clear cell, if patient cannot afford, we do use alone trastuzumab, but yeah, the data is for TDXT.
So, madam, about folate receptor alpha testing, is it done available here
Not
in
very
India?
routinely available, like we don't do it. If on request, we can ask for it, but we are not doing it. However, it is the protein, gene protein which we study on the tumor cells of the ovarian cancers, and moderate to severe intensive staining in more than 75% is what is required to understand the FOLR1 gene expression on the tumor cells. Usually seen in the high-grade serous carcinomas, and usually we are not doing it on a routine basis.
Thank you. Sir, one last question to Anand, sir. I will conclude the panel with this. What is the role of FAPI-PET? What is your thoughts about it?
Evolving because
Sorry. Yeah, there's a mic here.
So this test is now being done in Newburgh, and I've used in one patient who is from Kolkata. She's doing well. And another patient we have tested, and it was found 50% positivity rather than 75. But there is a new data, a new phase 3 trial which has come up that even if it is 50%, we can combine with another drug and we can use it. But by the time we were procuring, that patient become very downhill, so we couldn't use it then. But other patient is doing well, so this is coming in a good promising fashion.
Right. Oh, thank you, ma'am. That was.
The cost is definitely prohibitive, and that
Yeah.
is one.
So FAPI PET is usually done when the tumor markers are rising and routine FDG PET scan is negative. In those cases, FAPI PET definitely shows more lesion. So again, it helps in mapping of the such cases. Also, it can be used for treatment response assessment. But just like FDG, it has got lots of false positives also, and we have a big learning curve to go through. So I think FAPI PET will take a long time before it's get incorporated into a routine practice.
Okay, so in what are the false positives usually, sir? In PET, it's usually
Any
inflammatory.
inflammation, for example, if patient has undergone radiation also, any fibrosis for any reason, any inflammation can also give rise to false positive FAPI uptake. So FAPI is not cancer specific.
Okay, thank you, sir. Thank you all. Thank you for patiently listening to the panel and giving your extremely valuable inputs. Thank you, ma'am. Thank you.
I request Dr. Prashant Nyati to felicitate Dr. Anand Zade. I request for a group photograph of all the panelists. I request Dr. Prashant Nyati to felicitate Dr. Anand Zade. I request Dr. Anand Zade to felicitate Dr. Veena Vanare. Please give a huge round of applause. I request Dr. Veena to felicitate Dr. Prashant Nyati. Thank you so much, everyone. And to deliver the concluding remarks and vote of thanks, I would now request Dr. Jyoti to come forward. Yeah, ma'am.
So thank you very much, everyone, and a special, bonus. And I can see 2 residents, at least three, who are there till last. They should get some bonus marks for sure, some point of time. And thank you very much for everybody who, joined us today, and indeed wonderful sessions. I think it should be better kept on Sunday. That was my take home, because, everybody is writing that they want to attend, but they are in their OPDs also. So 2 things. Jaya recommended that it should be on Saturday, so I followed that. But I think next time onwards. But it was lovely to be with all of you, and great interactions. I would like to thank also my team and Apollo team, all the marketing team, who really helped a lot, and my core team from my OPD, and all the coordinators. Thank you very much. Yeah, Jay, if you want to say the last words. Thank you very much.
Thank you so much, everyone.
Thank you.